autumn, it used to be a summer meeting, but now autumn meeting and education day to the Neonatal Nutrition Network. My name's Mark Johnson. I'm the chair of the Neonatal Nutrition Network.
Good morning, everybody, and welcome. I'm Christina Korchaliudaki. I'm the educational secretary of the M3, and welcome to the online people and the people that are here in the room. Welcome to our educational day, and we hope you enjoyed it.
So we've got a packed program, and we're just here to say welcome. So we've done that bit. So we'll move on to the next bit already. So I'm going to hand over to my colleague Chris Forster, who's going to talk about where we're at as a group and our website and all those kind of things. Thanks, Chris.
So hi everyone. I'm Chris. I'm also a member of the N3, and welcome to our now autumn meeting. So just a little bit about the N3 and who we are. So the N3 was set up in 2003. It was initially known as the Neonatal Nutrition Club. So really catchy. So Nick Embleton and Pam Cairns were the founding members and the current members of the N3 committee. And the very first meeting was back in 2004 in Edinburgh. And there's some fresh faces there who are just as fresh today. And obviously the group expanded. And you know, it was initially a meeting of kind of like-minded neonatologists, dietitians, pharmacists, anyone really who had an interest in the world of neonatal nutrition. And you know, the aim then is very much the aim today, which is to improve the nutritional care of all the babies who come through our services around the country. So, well, we meet twice a year. And we regularly host education meetings, and this is our 10th educational meeting. So it is our 10th anniversary of the N3 kind of educational day. We do not receive any funding from any milk formula companies, and obviously every organizer, every lecturer, every faculty member who is here today helping deliver the day gives their time freely. So there are no honorariums or anything. So thank you to everybody who has given up their time today to come and hopefully deliver what is going to be an excellent day. We are very active in research in terms of thinking about research. What's the next research going to be? We've had a lot of time has gone from the N3 into helping set up and support a number of some of the fairly big nutritional trials, some of which are now finished, some which have just finished, and some which are still ongoing. And our business meeting yesterday, I think hopefully some of those discussions are going to help to kind of shape the next nutritional trials which are going to be coming through. So now here we are in 2024. So we still meet twice a year. So we're a group of neonatologists, pharmacists, dietitians, all from all around the UK. And we now have 2 educational meetings a year. We have our, well, it used to be winter and summer. We've kind of slipped a bit, but now spring and autumn. But you know, with that spring meeting now becoming more of a kind of research discussion, and we still kind of host our annual education days. And we are continuing to support ongoing research. And as we said, you know, hopefully some of the discussions we had yesterday are going to shape those trials which we're going to be seeing coming through the unit in the coming years. We're continuing to grow every year. So we've now got over 700 subscribers and members to the N3. And there's 320 people visiting our site every month now. And we're on YouTube. So, you know, big changes come over the last few years. But we do want that N3 website to continue to develop, because that really is your N3. I think, you know, we'd like it to be that first stop for people to kind of come for either, you know, resources, or at least be signposted to where to find those resources. But it would also be nice if we could help it to kind of stimulate discussion between professionals and experts on kind of nutritional related topics, and obviously supporting kind of new research ideas, which can come from anywhere. They don't have to come from within the N3. So this is our website. some of you may have seen it when you kind of came to register here, but we've got information there on all the kind of ongoing previous trials with links to kind of what they're all about. We've got resources on everything from enteral nutrition, PN, kind of supplementation, metabolic bone disease. There's a lot of resources there. A lot of those things will kind of link through to kind of the most recent kind of national or kind of European guidance. And we're also on Twitter, or X, formerly Twitter. Easier to say Twitter. So how can we do this? How can we develop that N3? Well, we've got some ideas. Is there an appetite there to have a kind of ask the expert session where you can post your questions and queries and we can relay them to someone who may or may not know the answer? Polls for, we had some discussions yesterday, but actually it would be good if we could get a wider consensus on what kind of practice is. We think we know what's going on, but actually probably a lot of what we found out yesterday is that we actually don't quite know what practices are around the country. So can we use it to kind of help kind of get that kind of what is established practice at the moment to help guide these things? And more resources, I don't know. Would guidelines be useful? Would more literature be useful? Are we covering the right kind of topics? So I think, these are all things that we'd like to hear from you guys about. Of course, there is a contact form on the N3 website. It's at the bottom. That's our website address. But, like I said, this is your N3. So we're hoping to kind of make that useful for all those people kind of within the world of neonates who have got a nutritional interest or a nutritional question. So that's all from me. So I hope today is as good as it always is and that you get something from the day. And yeah, I will pass over to our next speaker.
Morning, I'm Anne Hickam, neonatologist in Dublin, and so it's a pleasure to introduce our first speaker, who is Chantal Tomlinson, who has led on the NeoTRIPS, which is increasingly successful, the early milk feeding in small babies. And Chantal is no longer a trainee, but is a consultant now in the East Midlands, but has led on this. Thanks, Chantal.
Good morning, everyone. So the first disclaimer is I am not a trainee on the NeoTRIPS team. I'm a consultant working in Nottingham. I live in Yorkshire, glorious part of the world, if anyone visits or wants to go up there. And I'm presenting on behalf of our team of trainees from across the UK. They're on nights and holidays and various things, so I got drafted in, but I can't take credit for an awful lot of the work that's gone on here. What I'd like to do is just give you a flavour for, this was the first collaborative QI piece that NeoTRIPS have organised. So they've had lots of research studies going on for a few years, but this was the first quality improvement project. So I just wanted to give you a bit of a flavour for how the network across NeoTRIPS works. Some of you may have been involved, and give you a little bit of a feel for some of the results. When we get to the results piece, the data collection only closed about 12 days ago. So those bits are not for kind of sharing or tweeting or Xing or whatever we call it now, because the team are just working their way through, but I'm going to share some of the data with you. Emma and Alice are our core QI reps who've just stepped down from the committee. So an awful lot of the work that you'll hear about in this presentation is work that Emma and Alice led on. Alice is now a locum consultant in Wales, and Emma is an academic trainee in London, and they've worked through an awful lot of the sort of national collaborative stuff that's gone into this particular project. Just a quick show of hands in the room. So who's heard of NeoTRIPS? And who's been involved in the EBM Equip project, or their unit has, to their knowledge? So a smattering, fantastic. So NeoTRIPS, for those of you who hadn't heard of it, they were actually a really good proportion of you had. This is a national neonatal study group, and the whole aim of NeoTRIPS, as it was set up, piloted initially in London about 6 years ago, was to harness the power really of the huge number of rotating medical trainees that we have, and they are housed within MDTs, and they rotate over and over again, and really use the power of those individuals to gain gain them some experience in research and quality improvement methodology for the benefit of the whole team and the babies that we look after to try and improve some important neonatal outcomes. So we put calls out for research and QI priorities for the group every year, at least once a year. And the last 12 months project, just coming to an end now, was the Early Breast Milk Initiative. So I'm going to take you through just a little bit about how we did that. As I say, we've got our core committee who look after the research and the QI arms, and then we've got Alice and Emma who've worked centrally on the quality improvement side, and then we've got a whole crew of regional reps. So every neonatal network effectively across all 4 nations has had a representative or 2 representatives working in the EBM Quick project. And then we've had nominated unit consultant and trainee leads, and then MDT stakeholders from all across the board. So we've had really far in excess engagement for this project of what we'd anticipated. The quality improvement team have got a sort of a mission, vision, values and goals sort of set of what they're working for. So just to touch on briefly, if you haven't come across our QI work before, their mission in terms of from the NeoTRIPS angle is to empower a generation of doctors, supporting them to lead improvements in meaningful outcomes for babies and families. So we don't choose these priorities, we try and map them to other important initiatives going on. And it's through a collaborative QI process. So we want trainees to be resourced and supported to deliver high quality QI. So that somewhat is focusing on the trainee angle, and we support them to do that through national collaboration. And we really want to facilitate learning with and from each other. So that's a huge element of how this project focusing on breast milk has sort of been slightly different than some of the other projects NeoTRIPS have done, and focusing on sustaining those improvements. They decided as a committee that so we stand for the things that patients and families come first. We're really trying to champion trainee potential. Collaboration is at the core of everything we do, and we try to embrace equality, diversity and inclusion, always listening and always learning. And their goals that were sort of set out as a committee are that we co-produce through PPI, that we develop our QI experience, collaborate and always share what we're doing, disseminate excellence, prioritise safety and measure our progress. So quite a lofty set of things that we kind of stand for and try to do. But as a team, kind of set that out as our sort of true north, if you like. Where I came into this was that lining up the sort of NeoTRIPS side and the breast milk side. So about 8 years ago now, I set up a small sort of research project focusing on some quality improvement methodology across Japan and Canada, and was generously funded by the Churchill Fellowship to spend some time in both those countries, working in different hospitals and different organisations, looking at quality improvement and specific sort of sets of neonatal outcomes and how we might bring those together for the benefit of patients in the UK. So this sort of skill set, looking at how QI had been applied across the Canadian neonatal network in particular, and some of the outcomes that we were seeing from some of the centres in Japan, came together such that I was then part of the NeoTRIPS team in a sort of consultant support capacity. So this last year, as I say, the priority that was voted for was that we would focus on early milk for early babies. Now, it wasn't that no one was doing it, it was quite the contrary. Loads of teams we knew were doing fantastic QI work and attempting to improve the access of their smallest babies to getting early breast milk. The BAPM toolkit had come out a couple of years previously to sort of mapping out this project, looking at optimising early milk. And the landscape was very much that there were pockets of really fantastic practice, but people were telling us that they were struggling to bring it together and struggling to sustain that in some cases. And so the aim that the NeoTRIPS QI set up for themselves, this was their hug, their huge, unbelievably great goal. I don't know if any of you have read Gavin Oates' work. He talks about having your SMART objectives are great, but you need a hug as well, so you can aim really high. So the huge, unbelievably great goal they set for themselves was to see the proportion of infants born under 34 weeks who receive breast milk within 6 hours of birth increase to 85% in every participating unit by 12 months. And that wasn't because we thought this is the first time we've ever tried to do national QI, we're going to nail this, we can absolutely help teams to get there. It was so that we had this end point that we could work towards. But we measured a number of other things along the way, which I'll come to. we looked at, so 6 hours and 24 hours was a really pragmatic way, and we could talk probably for a whole day in itself about the evidence or not around when is the right time to be getting milk from mum, when should mum be expressing, when is a reasonable amount of time to be getting it into the baby. But we chose 6 hours and 24 hours as our 2 measuring points for the outcome from the quality improvement, with some measures of skin to skin within 6 and 24 hours and expression within 6 hours. And we tried to keep quite a small data set because we were very aware that the last thing we wanted people to be doing was hauling through loads and loads of data, and didn't feel that that was realistic that it would be collected. And various measures were sort of put in place to try and support right from the beginning the sort of ethos of learning with and from each other. So we set up offers of reciprocal visits for teams, so they could visit one another's units. Some people wanted to do that virtually, some people in person, and resources of sort of webinars, which I'll touch on a little bit more, and then a whole host of online resources. And the Churchill Fellowship funded sort of a follow-up pot, if you like. They called their Activate platform, so that we had a small pot of charity monies to look at supporting some of these resources. And some of that included software licensing to Life QI, just one of the QI platforms out there, so that everyone had one place that they could go to. And I'll show you some of the ways in which we set that up. I just wanted to introduce you to one of our, so through our PPI work, we had, this is Sarah, who was one of our parent partners, and she's produced a few different pieces for us. It's somewhat preaching to the converted if you're here at an N3 meeting, whether in person or online, but Sarah was really instrumental to some of how we designed our work, how we set some of our priorities. So I'm going to show you a short video from one of the learning conversations we did with Sarah. The video does have a few glitches in it. That's from the recording, but let me show you and introduce you to Sarah.
And at 28 weeks on the dot, I had a really big bleed that just did not stop. I lost 2 litres of blood and my body began to contract. So the decision was made to perform an emergency cesarean section. My baby boy Owen was born at 12th of June 2021 at 11:30 p.m. He cried when he was born, which was the most exciting thing in the world. But then he almost immediately needed to be ventilated. He was taken straight to the NICU at St Michael's Hospital in Bristol, which was where we were. I needed several blood transfusions. I was really quite poorly, and so I wasn't allowed to see him or go with him. I went up to him about 4 a.m. I was allowed to visit him then after I'd had some blood, but I needed to return back to the ward for more transfusions. So Owen was on a ventilator, but we were told he was a good size, he was doing okay otherwise, but we were then told he was going to have to be transferred to Southmead Hospital, also in Bristol. So really lucky in Bristol, there's 2 good NICUs. But a baby was coming in that needed surgery, and that baby needed the space at St Michael's, so Owen had to be transferred. So at 11 a.m, at 12 hours old, he was taken to another hospital in an ambulance. So I'd only seen him once. I made my partner go with him because I didn't want Owen to be alone. So this left me alone. I wasn't allowed to leave St Michael's as I had just had major surgery and lots of blood transfusions, and there was no bed for me at Southmead. So I was physically separated from my partner and my baby. I was really worried about my partner. Alone in that environment, we're not medical people, it's alien to us. We had no idea what the journey ahead would be. We'd been told expect to go home at due date, but that was 3 months away. Other than that, we were really unprepared. As you can imagine, all of this was not, particularly conducive to establishing breast milk expression. The midwife on the delivery ward helped me to hand express some drops of milk, which were sent in the ambulance with Owen. And I continued to hand express in my room over the next day, collecting little syringes, feeling really, really proud of myself. After another day, I was discharged and I was able to go meet my baby. This was when I was introduced to expressing with a pump. Owen's nurse that day was a really lovely woman called Sophie. She showed me how to use the pump and what to do. She was really kind, really supportive, and really kind of tried to empower me with it. I'll always be grateful to her for that. But I will be honest, pumping for me was awful. It was relentless. Every 3 hours. I found it really depressing. I never made enough milk. I also found it really quite degrading and humiliating. So I would be sat by his incubator, and doctors and consultants would be doing the ward rounds, or responding to Owen having another medical emergency, or trying to explain something really important to me and my partner. And I would, have my boobs out, hooked up to a machine that was wheezing in and out, quite embarrassing. But the main challenge for me was lack of supply. I saw a wonderful specialist, Kathy, really many times. I tried every size and setting going on the pump. I was prescribed domperidone, I think it was called. Nothing helped. I could only ever express about 50 to 80 mils. At a few days old, Owen's lung collapsed and he suffered grade 2 and grade 3 bleeds on both sides of his brain. He was heavily dependent on the ventilator and had very high oxygen settings. He needed to be oscillated, I think that's the right word, for some time, and he was also on nitric. This meant that he was nil by mouth for 2 weeks. This was obviously awful, but this enabled me to build up quite a freezer supply, and this was the only reason we had enough breast milk for Owen's NICU stay. Once he was back on the milk, he gained weight quickly and progressed. The kind of dichotomy there of desperately wanting him to gain weight, but each time knowing that he did, this would mean his milk intake would be upped, and the anxiety that I may not produce enough or we may run out of freezer supply was real. However, expressing 8 times a day for 13 weeks was worth it, every single second, for being able to breastfeed. My body really hated pumping, but it responded so well once my baby could latch. I had essentially managed to keep my supply up enough through skin to skin and pumping, so that when he was able to latch for the first time, it was just magic. It settled him, soothed him, got him to sleep. Yay. Which was incredible. I finally felt like his mum, and yeah, it was just all worth it for that moment. The bond it gave us was just incredible. I really felt like he was my baby for the first time, that he belonged to me and not to the hospital. Before that, he felt like their property, but he was mine. I knew him best. I knew how to make him happy. I knew what he needed, and what he needed was me. It was just completely empowering and transformational. And I really honestly credit it with saving my mental health through that time, and continuing. When he became ill, I would remember one of the doctor's words, that we could give him medicine and try and work out the right ones, but your body knows and will automatically provide what he needs. How magic.
I don't know how many times I've heard Sarah speak and chatted to her and had a coffee and all of these things, and I still find it really moving to listen to her, because ultimately that's the reality, isn't it? That's what we're trying to do. It's Sarah's experience brings out so many bits that's actually also the why of all of the QI in the world can miss over some of these subtleties. And actually hearing a mum say, and being brave enough to say, and she said in lots of meetings with us, those 2 weeks when he was nil by mouth was actually a bit of a godsend for me, because I felt like I could fill up the freezer. So this was one of the ways that we learned and shared some of that really nuanced stuff that I'm sure we all know goes on in our units and with our teams, but actually we don't often have the time to break that down and address it. This isn't the stuff that comes out on a ward round. This is the stuff that we sort of tried to enable some conversation. So Sarah's been a really incredible parent partner for the project. She's just approaching 28 weeks in her next pregnancy, so she wasn't going to do a new video for us today, but she's been fantastic. So the landscape was that what we absolutely didn't want to do was be recreating resources. We weren't setting out to recreate the Backham toolkit, to recreate any of the Scottish materials for health improvement. We were aware that lots of people had had kind of training through NeoTRIPS. There's so much going on across the 4 nations, but what we really wanted to do was try to sort of harness and bring people together with some of that resource, so that they could translate it from a kind of a concept into something that was actually the capacity for QI on their units where they worked. We did lots of engagement work. So we did lots of workshops asking people, why is the project going to fail? What's wrong with it? How do we make it better? What do you need? What steps can we take? And did quite a lot of sort of input work from that point of view, trying to co-produce something that would work for people. And then we laid out all of the resources that we had access to. So any projects that were going on from teams that were signing up who were willing to share, stuff that was already freely available online, and put all of that accessible through the NeoTRIPS website and through some of our other sort of portals so that it could be accessed. This is just one screenshot from, we chose to work with Life QI that preterm and a few other sort of national, regional or national projects had worked with. And this was one of the elements that was funded through our charity monies so that we could allow initially the regional reps and then ultimately every unit who was participating a login to the platform where we could lay out, they could download all of their data so they could share it real time, but they could also access the resources through there. And one of the things that was one of the most used elements was our sort of overarching driver diagram. So with the sort of the set out project aim that we wanted to get to that I've already touched on, we then set out laid out in a very prettier format, very prettier, that was lovely, wasn't it? Much prettier format than this. Actually, all of the primary drivers, secondary drivers, and every change idea that either people had submitted that was available in another resource or that our team had come up with. So for example, if ensuring that staff are educated in the benefits of and processes towards early breast milk, actually, what did that require? So for example, effective and timely communication about outcomes, and then some change ideas for PDSA cycles. So for example, monthly MDT spot checks, where people could learn from peers where early breast milk had or had not been achieved locally. Looking at the component of the diagram that parents were educated in the benefits of maternal breast milk and early expression. If, for example, we wanted maternity staff to have the training, capacity, opportunity and resources to educate parents in antenatal clinic, looking at preterm birth clinics to be able to offer some written, web-based or visual aids on milk expression for those families at highest risk of preterm birth. Everyone feeling facilitated and accountable for those preterm babies receiving their breast milk. So Mr. Y in there. So for example, staff routinely allocated to be responsible for prioritising early maternal breast milk. Ideas such as having the maternity care assistants allocated so that they were the person who was going to prioritise expression within the first 2 hours after birth. And empowering vitally parents as partners in care. That focusing on empowerment opportunities might include things like parents giving colostrum on the resuscitaire for those families who had been expressing and had antenatally harvested colostrum. So a little bit of the mechanism of how some of that came together was that software licensing provision. The local representatives through the NeoTRIPS network were putting in their data monthly. There were webinars that were either a sort of share and learn forum or a book club or a teaching sort of entity on QI or a troubleshooting session. Some quarterly data updates and opportunities for people to come forward with any challenges they were having. And then the team set up and ran an annual conference. So if anyone happens to have been to the conference in July, there we go, Alana was there. So we set up a conference, which I think 78 people attended in person in the day. On the day. So in the end, we had 73 units fully signed up to participate. We had about 115 who initially had expressed interest. And then in terms of making it through all the paperwork and data entry, we had between 50 and 65 contributing data entry. And that was the whole breadth from NICUs, LNUs and SCABUs. And we had representation from all 4 nations. We had about 350 signed up stakeholders who were either attending webinars, contributing data, or taking part in some of the other learning events or meetings. So the data bit, as I say, data collection has literally just closed. So this isn't all of it, and we haven't been through and done, sort of cleaned it, as it were. But what you can see, for example, the initial signal for our breast milk within 6 hours, from our baseline rate of somewhere between 20 and 25% for our participating units, and we had anywhere between 200 and 500 babies worth of data every month, and it varied a little bit. But you can see actually for the latter part of this, we've got the suggestion that we've got a signal of a true shift in our data. And actually for the last couple of months of data, probably north of 35% of the data that we have for babies getting their breast milk within 6 hours. And then for 24 hours, actually we had a baseline set of around pretty consistent, around 50%. There was a little bit more back data for baseline, but for the March data, we would have had a true signal in that. But hopefully what we're seeing there is an upward trend, and we've got, as I say, a bit more data to add on, but an overall trend towards increase within our 24-hour breast milk data as well. And expressing within 6 hours, not everyone was routinely collecting this data prior to the project. So this was a newer sort of data entry point for some, but we also have a more consistent trend among that data from a baseline of 30 to 35% up to 60 or 65% of the baby's data that we had for getting milk within 6 hours. Now, there's loads of caveats with QI data. We totally appreciate that. We don't have the same denominator every month, but we did have these units consistently giving us their data for their babies. So that's what we have for now. This slide I thought was in slightly earlier. So for our annual conference, as I say, we tried to run a bit of a combined programme, focusing partly on breast milk and partly on quality improvement. So it was part training day and part looking at the data in itself. And then we've got this really huge repository that we're just sort of really getting down to what to do with at this stage and how to share it even more broadly around, I won't read these through to you, but we've got this huge menu of interventions that all of our participating teams used as their kind of PDSA cycles. And just to go into a couple in a little bit of detail from our conference, so we had a really nice example from the North Central and East London team, where they had put in place a kind of a whole community of practice around this QI project, and they'd had meetings varying in frequency, they'd had some sort of targeted WhatsApp groups, and they saw an increase in their signal for their percentage of babies getting milk within 24 hours. And a group from Dundee who'd focused on, some fantastic medical students presenting this at the conference, they focused on the sort of education side, and they identified that actually their staff weren't aware of, or not all their staff were aware of, how often mums should be expressing, or actually that this target of 750 mils of expressed milk by day 10 to 14 was a sort of yardstick that we should be aiming for. So they focused quite a lot on their education side. But we've got all of these different ideas of sort of checklists that were employed, and exactly how teams went about improving their own data locally. Obviously, this was completely voluntary. So we had this pot of charity money which supported the conference, the training events, the software, pens, badges, stickers, all kinds of varied stuff. But it was a voluntary project at the end of the day, with no sort of actual commitment in that sense in terms of people's time. It was therefore, you know, we obviously saw the waxing and waning month to month. If a local rep was on annual leave, we perhaps didn't get any data that month. So it's not a perfect system, but actually the core materials and the core methodology were common to everyone. And that was one of the real blessings of this project. And we had a sort of training at the core because it was run through NeoTRIPS, but actually we found that the MDT stakeholders for every team and every region just grew and bloomed as the project went along, which was really fantastic learning for everyone involved. But as with any QI project, we found that people dipped in and out over time, and that was somewhat refreshing when they came back and they had a bit of an invigoration, but lots of challenges to running it. But one of the real takeaways for this was that actually we got to see examples and to share examples of some of the fantastic work going on. So people weren't having to recreate the wheel. They were just sharing their resources from team to team and network to network. It was feasible for us to run this national focused QI methodology, and we'll shortly be launching the 24-25 project focus for NeoTRIPS. We've just recently had a sort of sustainability development day, thinking about how teams, but also the national team, sustain this kind of project and this kind of work over time. And this is something that's adaptable to looking at some other project submissions that we've had. So looking at things like metabolic bone disease screening, bundles around NEC, we could lift the methodology and apply it and adapt it to other things as well. Of course, there's always going to be funding and resource considerations, so we have to be creative and think about how to do this. But it really afforded such incredible networking opportunities, and Alice and Emma worked relentlessly to keep things ticking along as the central committee. We wouldn't have had any of it without the trainee reps, the regional reps, the unit leads, but also every single stakeholder. So we know we had lactation consultants and dietitians and maternity support workers, and really a whole breadth dipping in and out of the project, for which we are immensely grateful. Thank you.
Thank you so much, Chantal. It was a fantastic initiative. It's also incredible to see how NeoTRIPS has grown. Now, we should have said at the beginning, but we've said to the online group is we're going to take questions on all of the talks at the end of the session. So we will move on to our next speaker. If we could ask everyone online as well, I think Mark's put it in, but if everyone could just type in their questions, that would be great. So our next two speakers are Christina Kursdaki and Stephanie Tecchini. Christina's a consultant, well known to the N3 group and at UCLH, and Stephanie is a dietitian at Imperial. And they're going to talk about what I think everyone is beginning to realize is the increasingly complex subject of nutrition in late preterm infants. So thank you both.
Can you hear us? Yeah. Lovely. So when we were allocated this topic, me and Steph were like, what are we going to talk about? What is it out there? And how are we going to fill those 20, 25 minutes with slides? And then I think we're going to overrun and we'll try not to, we promise. So it's a very interesting topic and maybe something that NeoTRIPS need to look into as the next initiative. So I will start. This is what we're going to talk about. I'm going to talk a little bit about the background. We thought not to make it too dry, so we brought a case to discuss together as much as we can because we need to speed up. And then Steph has the important part to go through all the nutritional requirements of the late preterm. It's going to shed a lot of light into what we need to do or what we need to look into. So this is the definition. We're going to talk about the moderate and the late preterm babies. This is the definition that we have from SPCAN, from WHO and BAPA. The moderate preterms are those that are between 32 to 33 plus 6, while the late preterms are those that are 34 weeks up to 36 plus 6. And these are some figures to understand why are we looking into late preterms and why are we looking into preterm babies overall. Yes, we do know that preterm birth accounts has a big range, and WHO figures, as you can see, are 13.4 million of babies born back in 2020, and the range can be between 4 to 16, depending on the area, the region. But the preterm birth has a lot of complications and is the leading cause of death for children under the age of 5. And then when we look in more focus in England and Wales, you can see the figures, they tell the story. There are 58,000 babies that are born prematurely in the UK per year, and of the preterm birth that occurs, 1 in 13 babies will be born preterm. But of those babies that are born preterm, then overall the preterm births do not decrease every year, as you can see, but 84% is estimated to be late to moderate preterms, babies born between 32 to 37 weeks. And therefore, preterm birth accounts for the rate overall increase, but probably is the late preterms, late to moderate preterms that are increasing that figure. And definitely they account for the 6 to 7% of all the newborn population. And why is this happening? And we know that there are differences in demographics. There are the maternal age has increased, and also there is a lot of fertility treatments that probably contribute to that, and lots of other causing factors that we can spend the whole day discussing about it. Definitely there is risk associated with preterm birth. We all work with neonates. We all know that this is there. But when we talk about risks related to preterm birth, that is from the 22-weeker or 21-weeker, 22 for the UK, up to reaching to 37 weeks. However, what we know about the late and moderate preterm babies is not very well studied. And what we tend to assume that these babies are expected to do almost as good as the term babies, but that's not exactly the truth. And we started now to recognize that there is increased risk for adverse neonatal outcomes and a poorer long-term outcome for this group. And there is an increased risk for morbidity, but also the short-term mortality. There are studies that have shown that the overall health, the neurodevelopmental, as well as the educational outcomes of these babies are poorer compared to the terms. And there is where nutrition has a place. And it's definitely the nutrition is going to determine the better growth and a better development. And however, we don't know exactly what are the nutrition requirements and for the optimal growth and development for this group. What we know is that by the third trimester, the brain is still growing, is still maturing in the last 6 to 8 weeks of the pregnancy. The body growth is really rapid during that period. And there is significant difference in the body composition during that period. So if you've been born before you get to term, there are significant parameters that they have not reached what a term baby would look like. And as a consequence, we have poorer growth rates and intellectual development. This group has been highlighted that has higher risks for metabolic and cardiovascular disease, and there are higher risks for morbidity and mortality, but also hospital readmissions. And this is something that probably we all have been challenged for this group. What do we know now about body composition difference? This is a paper that is back in 1976, but a paper that everybody refers to when we talk about body composition differences. And what it tells us is as the gestation increases, the concentration of water, sodium chloride is decreasing, while as the gestation is going up, protein, lipid, calcium, phosphorus, magnesium, and all the other important nutrients are increasing. So again, and that affects definitely the group of babies that we are discussing here, the late to moderate preterms. And as a summary of that, you can see that in this graph is a more simplified summary of what's happening to the fat composition. Those that are born that less than 30 weeks is lower, it's getting a little bit higher between 33 to 37, and it's very different when you are a term baby. And then a new study, this is the most recent study on the late preterms that comes from the Newcastle group. There are lots of people in the audience that can tell us more about the Flamingo study. Recruitment has stopped. The aim of this study was to improve the understanding of the longitudinal growth, body composition development, and phenic characteristics of this group that we are discussing here. And a recent paper that was published from the Flamingo study data they have reported on what happens on the growth and the body composition of the late preterms up until 3 months of follow-up. So the total number of babies, there were 107 between 32 to 36 plus 6 weeks of gestation. They were stratified according to the feeding at the time of enrollment. And the team performed anthropometric and skin fold measurements, as well as for the body composition, they used DEXA studies. What they showed, and what is very important for us, is that breastfed babies had a lower fat mass, while they had a greater lean body mass increase, and the lean mass index has increased by 3 months of follow-up. So that what it tells us, this study is telling us the importance of supporting and promoting the breastfeeding for this group. And that has implications for the later term, the later life development and outcomes. But we're still challenged. And the moderate preterm, the moderate late preterm babies, those that are between 32 to 34 weeks, we are more clear how we're going to manage them. Those are babies that are well, they come to the special care, they are admitted to the neonatal unit, they are supported. However, we are challenged with those babies that are the late preterms, those that are 34 weeks to 36 plus 6, because there are no clear practices how we are supposed to look after these babies. And yes, recently there is the BAPAM framework of practice around neonatal transitional care that hopefully we all know, and we are all moving forward to implement that in our local units. And what we also know from the LAMP study that was done is that when they looked into the late preterms, those babies that are expected to do well, that they were placed in the postnatal ward, they ended up being admitted to the neonatal unit. And 50% of those babies admitted, they were reviewed by the medical team, by the neonatal team by 2 hours of life. So maybe we're setting up a little bit of unrealistic expectations for these babies. And we need to, and we also need to take into account all about parental anxiety and how we educate these parents to support and feel confident to look after and understand the babies. So definitely more work is needed into that. And why are we bothered about this group? Well, the common neonatal morbidities in the late and the moderate preterm babies, they have high risks for respiratory complications after birth, respiratory distress, TTN, apneas, high risk for infection than the terms. They have high risk for hypoglycemias and need to be monitored, and they have problems with hypothermia and hyperbilirubinemia, as well as feeding difficulties that we're going to discuss later. This is the transitional care neonatal from the BAPAM guideline, the framework of practice, and they suggested that babies that are well and they do not require intensive care support or high dependency, and they are between 34 to 35 plus 6 weeks, they should be admitted, and there should be a lot of effort to keep them with a primary carer. And also they also define the gestation, the weight criteria to be less than 1,600 grams, or those that are less than 2 kilos to be admitted under transitional care. And we know the challenges around that about capacity, and I'm not going to go into that. And recently there was another framework of practice from BAPAM on moderate to late preterms and how to look after that, recognizing that this group of babies have increased morbidity and mortality, and they also require enhanced postnatal monitoring. They have high risks for infection, high risk for respiratory distress, as we discussed, and the mothers need a lot of support on breastfeeding. They also said that early discharge should be avoided if possible, and they need support in the community. And parental education is crucial. They picked up on family integrated care importance. They suggested criteria for discharge to help the teams. They also suggested where, based on the gestation and the birth weight, where would be the most suitable place of admission, as you can see on the figure 1. And they suggested how to look after them if they are admitted in low dependency, and what is important on observations, on thermoregulation, and supporting the nutrition and monitoring for hypoglycemia. And there is this paper that a lot of people that are again in this group, Mark, Steph, have looked into, have sat together and say, what do we need to know about the nutrition of this group? So it is in everybody's radar that this group is increasing, and we need to do something. So they made some recommendations that are very useful. They suggest the paper is suggesting that we need to focus and encourage the breastfeeding, support the mother either on transitional care, or if the baby is admitted to special care, consider the donor breast milk if, depending on the local guidelines, and if required for the baby. And I think Steph is gonna tell us a little bit more on that. Consider to introduce breast milk fortifier if, again, is baby is required. NG top-ups with expressed breast milk to be considered as well. Support at discharge by midwife and health visitor. Also to consider, and then they touched on formula and preterm formulas, and they suggested that we could consider it if needs to be supplementary to the breast milk, and not to forget about iron supplement, about vitamin supplementation for this group, and vitamin D supplementation for this group. And I'm not going to bore you about the SPGAN recommendations. They focus again on the same things that I've mentioned before, and most important is that how we're going to support these families, how we're going to support the mother and the baby, how we're going to support the breastfeeding, and not to forget about the importance of their nutrition and their vitamin and iron and vitamin D supplementation. So I'm going to move quickly to the case study before Steph takes over, because we're bringing to you probably a moderate preterm baby, I would say, of good size, 32+6, female infant. Mom has a complex obstetric history, and she's been admitted with prolonged rupture of membranes, a typical story so far. And then they eventually, she's been on the postnatal ward, but they have to progress with cesarean on the labor ward, sorry. But they have to go ahead for an emergency cesarean section for fetal bradycardia. Baby is born in reasonable condition. They followed all the care that is required, had some respiratory symptoms, and was admitted to the neonatal unit. So what are your thoughts here? Anyone in the group, that what would be your concerns or any challenges that we may have? He's a very good size baby as well. So I suppose it's the complicated labor by prolonged rupture of membrane. So there are some risk factors for infection, and the team has started antibiotics, but also a mom that might be unwell in herself, and the baby needs admission despite that is of a good size and a good gestation. And then how would you consider the nutrition plan of such a baby? Any thoughts? Mm-hmm. Okay. Yeah. Yeah. So I suppose support the mother to express. Would people start formula with this baby? Let's see. This is your growth chart. And this is what happened with early support. Because the baby had respiratory symptoms, we started fluids, an NG tube was inserted, and mom was supported to express and to have some early skin to skin as soon as she could come on the neonatal unit. And they tried to give baby early colostrum. Any other thoughts here?
An online comment, Christina, if someone does say, or worrying, would be neglected.
Point
They're
taken.
also supporting early expressing.
Yes, support early. It's very important, and the mom was offered that. But this is how this girl progressed. She had an E. coli, early onset sepsis, and then also meningitis. That was confirmed very early on at 36 hours. And she ended up required to be intubated and ventilated because of apneas. She didn't have seizures, if anybody asks. And she developed very early on being unwell, milky aspirates and bilious aspirates, and the abdominal X-ray though was normal. So she did receive colostrum, but we only had it by 24 hours of life. And there were difficulties to get expressed breast milk because mother became unwell and she had the same sepsis. And this is where we need to consider what happens with mother in this type of situations. But are there any other thoughts? What would we do when we get to this point? How will we support the nutrition? PN, okay. Would people give PN in the room?
If for donor milk, commenstropic feeds at least 10 to 20 mils.
Okay.
Yeah.
It's in the guideline.
Donor, and buckle from the online group.
Thank you. So this is what happened to her growth in the next few days. Her weight dropped while she was on antibiotics, and she was poorly trying to recover, and the antibiotics were changed for meningitis doses. And the progress is that she's going to have a long course of IV antibiotics given the diagnosis. A long line, yes, was inserted because we were struggling with feeding, and she had parenteral nutrition. And by day 3, and that's been our local guideline, but different hospitals have different guideline. And then we managed to get EBM as mom was recovering by day 4. Day 6, he was extubated. He was in high dependency because he has a long line, but he's breathing in air, self-ventilating in air, and mother remains impatient. What would be your concerns? So baby and mother are not. Mom is still unwell on antibiotics. So you had growth chart. So. Yeah, that's very true. You need to follow the cues. Those is a 30. She's just recovering, so depending what the baby's cues are and how we're gonna support. And then it's how you're gonna support the nutrition from a baby recovering. Yes, a good sized baby at birth, but having a very severe complication soon after birth, and this infection that's gonna need to be in hospital as well for a long course of antibiotics. And so the ability to reunite with mother it will be prolonged and affected by all this. And this is where we are concerned about this group. I will get to Steph.
Oh, I've still got to do my whole bit. Thank you, Christina. That's absolutely brilliant summary. And so I'm going to move on to nutritional intake specifically of what we might be giving to this cohort of babies. So as you all know, we've got really clear guidance for those less than 1800 grams in the ESPGHAN guidelines. And we've got pretty clear guidance as well, which we use particularly as dietitians for term babies. But there's not a huge amount of guidance of what we feed those babies over 1800 grams and less than term. What we do know, and what we know is solid evidence, is that we need to give these babies breast milk and breastfeeding. So the most important thing I would say is lactation support. So we know that mothers of this cohort of babies should be given advice and support to increase their milk supply. We know that we should all be following the standards of UNICEF BFI, so close and loving relationship, receiving breast milk, and parents as partners in care. There's evidence to show that professional support significantly improved exclusive breastfeeding. And what we need to make sure we're suggesting to mothers is that they express until term to maintain their supply. So it's likely that these babies are still immature, may not be efficiently removing all the milk from the breast. So this is a slide just to demonstrate these are term babies and how much milk they're actually drinking. And all I'm trying to demonstrate here is that you can see that up in the milk supply in the first few weeks of life, and then it becomes quite stable after that point. So it's so important that we make sure that we get the mother's milk supply up really early, and particularly in the first sort of 5 days, 5 to 7 days, we want to be supporting that mother to get her milk supply up. So this is just to demonstrate, slide courtesy of Caroline King, thank you, just how much milk, assuming a baby was taking, we don't know what these babies are taking, but say they were drinking 200 mils per kilo per day, which is quite high, but say they were, this is how much milk the mum needs to produce. So say the baby's 1.5 kilos, we're looking about 300 mils a day. So when we're on ward round and we say, wow, it's all mum's milk, this is brilliant, we congratulate the mum. I mean, we should be, that's fantastic. But actually, this is how much milk the mum should be producing for her to be able to then fully feed her baby on discharge. So we need the mother to overproduce. We need her to be putting milk into the freezer in those first, maybe not first couple of days, but within the first week, we want her to be overproducing to enable her to fully feed her breastfed baby when she goes home. So there's evidence to show that actually receipt of formula milk as the first feed can actually be associated with a reduction in exclusive breastfeeding, particularly by 6 weeks, and length of stay can actually be increased in this study by up to 3 days if given any formula milk. But there's actually a risk of lower breastfeeding rates in this cohort of babies specifically. We know there's shorter duration of breastfeeding compared to term babies, and there's also greater risk for breastfeeding rehospitalization and poor breastfeeding establishment compared to term babies. And this has an adverse implication, both economic, but also emotional for the bonding of the mother and baby. And there's actually within this risk group, there's even higher risks. And this study showed particularly that mothers with lower socioeconomic status and single mothers were even more at risk. But what we do know, as I said, is providing more information and support increases breastfeeding initiation. So it's just a demonstration. I'm sure you're all aware of this, but we have to remember this cohort of babies are not term babies. Their feeding development is still in progress. They may have immature suck, swallow, breathe, and their sleep cycle as well might be immature. So they're probably having longer time asleep, less time alert, but they need that sleep time for them to grow, develop, repair. So we can't interrupt that sleep, but equally, they're not necessarily going to be feeding the same as a term baby would. It's also worth noting that growth is quite different in babies born at term or babies born slightly earlier. So if you take a baby born at 40 weeks on this growth chart, ideal growth, which we don't always see, it would take 18 weeks for this baby to double their birth weight. But a baby born at 33 weeks, they have to do the same, double their birth weight in just 10 weeks. So there's a huge amount of growth that's going on in these near-term babies. So what are our growth goals? Well, I think we all unanimously agree we need to have weight, length, and head circumference. All three are required. We know that these babies have likely got higher requirements and potentially less ability to get the volumes of milk. So they need close growth monitoring and support. There's been some suggestions for how much growth we should be expecting, which I've detailed here, which is higher for the earlier babies and less for the later babies. But as we all know, the best way to track growth is on our NICM growth charts. But do remember the limitations of these charts, which is a whole lecture in itself. But just remember they're cross-sectional preterm birth weight data, and the term charts are based on term well breastfed babies. And you're going to get that change in the chart when you cross over from one to the other. But what about long-term outcomes in terms of growth? Well, the Esbjerg paper suggests that just by being late or moderate preterm, you might have long-term effects not only on growth, so higher risk of lower weight and height, but also other factors, so blood pressure, insulin resistance, glucose tolerance. But there's a lack of data to really see the effects of early nutrition on what happens later on after discharge. There was one paper this year suggested no association with nutritional intake and growth up to 2 years. So they looked and they found that actually, even though these babies were not meeting nutritional requirements, they did still seem to grow. So that it's out there really about long term. The Flamingo trial, which Christina detailed, is going to be great. It's going to improve our understanding about growth, body composition, as Christina detailed earlier. This is an interesting survey which was done in the Australia and New Zealand network, a survey of what do people do? So I would be really interested, made me think I'd quite like to do this survey actually in the UK. What are we doing with these babies? And not surprisingly, there's a huge variation in practice of nutritional management of this cohort of babies, and it's likely due to the lack of evidence on which to base our clinical practice. So the majority of clinicians, however, were really happy to provide only dextrose, 10% dextrose, for up to 2 to 3 days, despite it only containing carbohydrate. So again, as someone mentioned in the chat, these babies can somewhat be missed. So this is just a summary table. It's quite messy, but I tried to put all on one page, all the different nutritional requirements that we've got. So at the top, we've got the less than 1800 grams. We've got the term requirements. These are the suggestions from the Lapalone 2013 paper, which is somewhere in between. But the Esbjerg paper concluded that actually there's really a lack of data. We can't determine precise nutritional requirements in this cohort of babies. I've just put it at the bottom for comparison, mother's milk. What we can do is we can look at fetal weight gain. So if we look between 28 weeks and 40 weeks, we can see that the weight gain per gram per kilo body weight is obviously considerably higher for an earlier preterm compared to late preterm and term baby. So do we just mirror this? Do we just say, well, they need to gain more weight, so therefore they need more of everything? So what about energy? Well, we think that the needs are going to be higher than term babies. And again, the Esbjerg paper, if you're interested, had some interesting research in it. So it could be up to a quarter higher than for term babies. Resting energy expenditure might actually be higher in small for gestational age babies compared to appropriate for gestational age weight babies within this cohort. And potentially the energy intake per kilo body weight is linearly associated with weight gain during the first month of life. So what about vitamins? Well, again, might be higher, probably are higher. It's been found when they've looked at levels of vitamin D that actually seem to be suboptimal in the first 3 months of life in this cohort. And actually some of them had elevated parathyroid hormone as well. But what we do know is that vitamin D should be provided for all breast milk fed babies from birth. So 400 units per day, that's SACN requirement from 2016. But there's insufficient data to say precisely what we should be giving to late preterms, and we need further studies to know if higher doses are actually beneficial. So this is the SACN report you're probably all familiar with. What about iron? Well, these babies may have lower iron at birth, and one study found that actually nearly 40% of babies at 6 weeks in this cohort were actually iron deficient. But we're getting better at doing cord clamping, so some of this might be ameliorated. But what we do know as well from the Berglund studies, which you may hopefully be familiar with, is that babies with birth weights between 2 and 2.5 kilos, regardless of their gestation, if they're given iron, then they had better outcomes. So these studies looked at giving no iron, 1 milligram per kilo per day and 2 milligrams per kilo per day from 6 weeks of life to 6 months. And they found that the babies that were given the 1 to 2 groups had decreased risk of iron deficiency anemia, less behavioral problems, and significantly lower scores in aggressive and rule-breaking behavior. So also thought problems. So it looks like there's actually not just to do with anemia, but there's actually long-term outcomes in terms of giving iron to this cohort. So Esbjerg recommended that we should be giving iron to this cohort of babies, less than 2.5 and less than 2 kilos. And this was incorporated into the supplementation of vitamins, iron and zinc deficiency from the British Dietetic Association, which was published this year. So we are now recommending that any baby that is less than 2.5 kilos should be given iron. What about fortifier? I could talk about this all day, so I won't. But we know that less than 1,800 grams, there's a huge amount of evidence to support the use of breast milk fortifier. But should we be considering it for babies over 1,800 grams and less than 32 weeks? Perhaps there's suggestion that if their growth parameters fall down equivalent to 2 centile lines on the NICM growth chart, then yes, we should be considering it for these older babies. It can be used in some centres just for any baby less than 1,800 grams, regardless of gestation. But there is evidence as well that it can support later breastfeeding. So it might be something that you might want to add in for these babies. What about formula? Well, it's unclear if it's beneficial or not. It may improve growth, but neurodevelopmental outcomes are debated. The Cochrane reviews, not specifically on this cohort, but they found that there wasn't consistent evidence on long-term growth for preterm formula and nutrient and risk post-discharge formula. A couple of studies published this year looking at adjusting the type of formula milk that was given to babies to look at body composition, and another one looking at if we supplement in this cohort of babies enteral feed, so maternal milk, supplementing it with either PN versus IV dextrose, so supplementing it with formula or nothing, so just waiting for mum's milk to come in. But they didn't find any difference in body composition at 4 months corrected gestational age. And then they also did another arm, which was looking at giving babies a taste and smell of milk before they gave every enteral feed to see if that increased time to full feeds, but they didn't actually find any differences. So talking about PN, do we give PN to these babies? Well, the NICE 2020 guidelines state that any baby over 31 weeks could start PN if sufficient progress isn't made with enteral feeding after 72 hours from birth. Very few babies will fail to progress, but we do need to remember that sometimes, as Christina presented, this might be used. But then what PN do we use? Do we use preterm? Do we use term? So again, it's all out there really for more questions than answers. What about DHA and AA? So it seems that at birth, there's a significant correlation between gestational age and how much DHA and AA there is in the baby. And there's one study showing that 30% lower DHA is observed in these babies compared to term babies. So they might be higher, they may have higher requirements, but we don't know precisely how much. And you have to remember that DHA and AA are going to be in breast milk. So again, coming back to we need to breastfeed these babies. What about how to start these feeds? So generally they're on NG feeds. They may go straight to the breast. The SIFT trial was informative in those less than 32 weeks, and the Feed 1 trial is going to inform part of this cohort. But what about the 33 to 37 weeks? Where do we start? How do we progress? What do we do with these babies? So one study looked at starting 100 mils per kilo and found that they reduced the risk of hypoglycemia and length of stay. But this study was looking at starting 100 mils per kilo and then getting to 200 mils per kilo, I think by day 4 or 5. And the other group was starting at 60 and getting to 170 by day 9. So it's sort of one extreme to the other. So just something to consider there. But if we did do this, if we did start at 100 mils per kilo, what milk are we going to give to these babies? Can we expect mothers to produce that much milk? And if they can't, what do we then do? Do we add formula with all of the repercussions I've already mentioned? Or do we give donor milk to these older babies? So what do we know? Lots of what we don't know. This is what we do know. So we know cue-based feeding. So babies leading and mothers responding. Lots of evidence to show this is how we should be feeding these babies. Appropriate breastfeeding assessment. Ideally avoiding bottles. So up to 80% of late preterms are given formula milk because of challenges establishing breastfeeding. But bottles usually will not get you home faster. And formula feeding is usually because the milk supply hasn't been established. So what we need is support, not a bottle. And if they are bottle fed, just to note that using elevated sideline can be beneficial as well for this cohort of babies. We need to use good NG top-up charts and other assessment tools, non-nutritive sucking potentially, skin to skin, and family integrated care. So these are some of the things we should be using, which often get forgotten. We use them for our younger preterm babies, but not necessarily for this cohort or those on the postnatal ward. So NG top-up charts, breastfeeding assessment tools, good signs of milk transfer. So family integrated care. Now this is a challenging one because we want to keep mum and baby together. But also, if mum and baby are not together and baby's on neonatal unit, we need to get accommodation for parents, which isn't always possible. So we can do things like there's sibling packs, there's an IFDC app, but FICare is recommended particularly for this cohort, but also in national reports. So obviously in the moderate late preterm infant and also in the FICare framework for practice. So interestingly, this has been promoted by Bliss, and hopefully, I believe it's April next year, there's going to be, government are going to put into place the neonatal care and leave and pay bill, which will enable parents to have additional leave and pay up to 12 weeks to stay with their babies, which will be fantastic. So neonatal versus postnatal, well, we're all very good at giving vitamins and iron on the neonatal unit, but does it actually happen on the postnatal ward? So we need to make sure that we're doing it for both, having links with infant feeding, having clear guidelines, and having discharge letters that cover not just neonates, but postnates as well. Community support. So again, there's sometimes a bit of a difference between neonatal follow-up and postnatal follow-up. There's varied nationwide support for NG tubes at home. Breastfeeding therefore may not be sustained. There might be a risk of readmission. This was an interesting one. I don't have time to give the detail, but the care education program for mothers of late preterm babies seemed to be a useful intervention where they gave lectures to these mothers and gave them a booklet specifically about late preterm babies and how to look after them at home. But it showed an increase in breastfeeding and much improved psychological parameters for the mothers. And what about BMF on discharge? It's now on prescription, but should we give it? And ideally, it's going to be supervised. So just talking about this provision of care, of transitional care versus neonatal unit. So, yeah. Okay, I'll summarize. So there's summary, take home message.
Okay. So thank you all for bearing with us. It was a long talk. Always to promote breastfeeding and consider to provide the breastfeeding support for the mother from very early on, promote the skin to skin, invest in family integrated care, consider NG tube top-ups, especially with the breast milk, and we'll only consider the formula when it's necessary, fortifier, donor milk, PN, when it's required, please consider it for this group. Don't forget the vitamins and the iron supplements, and remember the individualized holistic approach for the MDT team to be involved. There is clear need for further research, and I think this is where we're moving towards, and this is what we understood from all the research that we've done. So we're gonna stop here, and a big thank you to everybody.
I'm delighted to introduce Professor Nick Emerson, a well-known group, one of the founding of the founding fathers.
Yeah, founding father.
It's
tidbits here because this is the 10th anniversary of this session, so it's fitting that today. He's a consultant neonatologist in Newcastle medicine, and we're lucky that the fair stopped in the UK, which is 4 weeks before. So it's about human fortifiers.
Right, thanks very much, Mark. Thank you to everybody for coming today. It's great catching up with everybody again. So I'm going to be talking about the role of human milk fortifiers. Whenever we're talking about anything to do with industry, I think it's important we're completely transparent about funding. So I have received funding from formula milk companies as well as NeoTRIPS. I have been offered speaker fees, which have gone to charity for the last 5 years, and I am involved, foolishly, potentially, in this massive lawsuits that are going on in the US, and happy to talk to you about that over coffee. And in addition to all of the standard conflicts, I have some other sort of conflicts and biases. I love traveling, going to conferences, and I'm, of course, like everybody else, obsessed with their H index. And I need to disclose that in 2016, Proactive flew me business class to LA. I suspect that's the last time that we fly me business class, if at all. Okay. So when we start thinking about human milk, we're thinking about human milk fortifiers, think about kind of what is the whole aim of feeding babies. Of course, what we're interested in is maximizing survival in these babies, but also avoiding disease like NEC. And as Steph was talking about in the last talk, very much focused on, how do we protect and promote brain growth in these babies, and not to ignore the challenge that all of us face every week on the neonatal unit, which is this walking of a tightrope between, on the one hand, wanting to feed babies and make them grow, on the other hand, being concerned that using formula or fortifiers or some other practices might increase the risk of NEC. So this is the tightrope I think that we all recognise we face. And then when we're thinking about growth, very much to think about growth within the kind of concept of the developmental origins. So as we were talking about with the late and moderately preterm infants, there's evidence that even being born just a few weeks early resets your metabolism for the rest of your life. And so a lot of our feeding should be aware of this. But as I say, what we really want to do is avoid NEC. All of you probably will have seen babies with NEC. It's a dreadful disease, and it has profound impacts on brain development for these babies. So we have to try and get this balance right. So when we're thinking about human milk, I've always been fascinated in evolutionary biology. There's some fantastic work written about how breast milk composition evolved. Why is it that we have breast milk, and what did it start off as? And when you look back in evolutionary times, the primary role actually of breast milk was to provide bionutrients, immunonutrients that decrease your risk of getting infection. That actually was the primary role of the forerunner of mammalian milk. But then when you're a human, we realize that human milk has to provide for all of your dietary needs for at least the first 6 months of life. The next aspect that we're increasingly interested in is the role of the microbes. We know that certain patterns of microbes may be associated with NEC, but may also be associated with health benefits. And then also, of course, breastfeeding provides this communication between the mother and her infant. So when I talk about nutrition or human milk, I want to kind of present that a lot of what we're talking about really, we're discussing what's actually a complex intervention. So of course, all of us are interested in your macronutrients, your micronutrients. But in addition to that, particularly when we're thinking about human milk, we want to be thinking about all of those other nutrients, human milk oligosaccharides, growth factors, and hormones. As I say, we're increasingly recognizing the role of microbes in promoting health, but also potentially being associated with disease. Obviously, human milk oligosaccharides promote a specific composition in breastfed babies. But we've seen in our studies that the environment, that the NICU environment determines what bacteria you carry. And of course, this is also related to whether you think you should be using or not using probiotics. And then the fourth element, I think, of nutrition are these socio-behavioral aspects. So we talked about that work from the New Zealand group looking at programming of taste and sensory aspects, but also for all of us being aware that we live in a commercial society where we're being faced with pressures from formula milk companies or other companies potentially to use their products. So this is what nutrition is. Nutrition is not just nutrients. And when we're thinking about it, we need to think that breast milk is more than simply a vehicle for providing food. Now, all of you know that many mothers face a shortfall in mum's milk, and donor milk is widely used to make up that shortfall. But the high macronutrients we've been hearing about may mean that you don't meet the needs of babies without additional fortifiers. And of course, this age-old question, does exposure to cow milk fortifier increase the risk of NEC? And should we be promoting the use of an exclusive human milk diet, EHMD? Is it beneficial? And when we think about this, really what we're interested in is, does it have an impact on NEC? Does it have an impact on brain development? So the challenges are, should we use donor milk or formula where there's a shortfall? Should we routinely use fortifiers? And if we do use fortifiers, should we use a cow milk or a human milk? And I'm going to try and cover some of that in the talk. So there are various study designs, and it gets a bit confusing when you have these studies presented to kind of quite understand what they are. So I've put them, simplified them here. So there are 3 key studies where babies were randomized to either getting donor milk or preterm formula. So that's blue for donor milk and green for preterm formula. But they all received fortifier, and in these 3 studies, the fortifier was a cow milk fortifier. So that's one study design. The next study design is where you get mum's milk. If there's a shortfall, you either get donor milk or preterm formula. And if you use a fortifier, you either use a human milk derived fortifier or a cow milk derived fortifier. Somebody tried to cut me. And then the third type of study design is the exclusive human milk diet, where you have routine use of donor human milk, but you randomize them to either getting fortifier of human derived or cow milk derived. So you need to kind of carry in your head that there are 3 different types of studies that we can be discussing. This study came out just a few months ago. This is the large US milk trial that they started recruiting to in 2012. It just shows you how difficult it is to do these studies. Almost 500 patients randomized, equal numbers randomized to donor milk or preterm formula. Median gestation 26 weeks, a very high risk group of babies. And the primary outcome was on the right of the slide here, which is a Bailey at 2 years of age. And you'll see absolutely no difference between babies who receive donor milk compared to formula. This population is different, I think, to a lot of the UK populations we have. 50% of them identified as being Black, with very high rates of low maternal education. This was quite a complex trial, as I say. They started in 2012, and it took them a long time to recruit. And note that even though this is quite a large study, 400 odd babies, 100 of them received no mum's milk at all, and the vast majority received very small amounts of mum's milk. So this is very different to the Dutch early nutrition study I mentioned later on. And when we think about all these differences, and we want to compare it to our practices, we really should be asking a question: does the data from this study generalize to our UK populations? They used fortifier routinely. Do we think fortifier should be used routinely? And as I say, introduction of feeds generally was slower and later than what we would see in the UK. So when we do these studies, and they take 10 years to do, the goalposts are moving. Right? Practice back in 2010, 2012 is probably a bit different to what we face now. But importantly, important to recognize that despite there being a difference in NEC between the 2 groups, there was no difference in the Bailey outcome at 2 years of age, and no difference in mortality. Indeed, mortality was higher in the donor milk group. And that should just make us question whether everything that we've been told about donor milk really is true. If donor milk really does significantly reduce NEC, why does it have no impact on mortality rates? And indeed, if you wanted to pick around with the data, you'd say, well, look, actually, mortality is 20% higher in the donor milk group. Now, if you want to believe donor milk's great, you'll say, well, that's just a secondary finding. Fine, it might just be a secondary finding, but then you want to take NEC as a secondary finding as well, right? So I think there's really quite a lot that we've still to learn. And like a lot of other studies have shown, weight gain was slower in the donor milk group, because even when you use a standard amount of fortifier, you know you will not meet macronutrient requirements. So just a note of caution not to over-interpret data on donor milk. So what can we conclude? I think we conclude randomized controlled trials are incredibly hard work. I think we can now be reasonably convinced that there's no impact on brain development at 2 years of age. NEC, to me, looks lower. I think this is consistent with the other data, but the babies still grow more slowly. But as I say, generalizability of this study to the UK setting perhaps is challenging. So let's move on and look at some of the other studies. This is Deb O'Connor's Domino study, over 300 babies from 4 NICUs in the States. Just look at the study design. Everybody gets mum's milk. They either get donor milk or preterm formula, but if they get a fortifier, they both get cow milk fortifier. So they followed this for the first 90 days. But note that out of these 360 babies, more than 100 never ever received donor milk or preterm formula because there was sufficient mum's milk, right? So it looks like a huge study, 360. If you take out those 100 babies who never get exposed to the intervention, you're down to a study of 250. Not a big study, but they did see, as a secondary outcome, less NEC in the donor milk group compared to the formula, and that was significant. Again, you would all say, well, I believe this is true, it definitely reduces NEC. But actually, if you look at the data on your developmental outcome, you'll also see that there was a higher proportion of babies with lower developmental scores in the donor milk group. So if you want to believe secondary outcomes, you either have to believe it reduces NEC and it might harm your brain, or you can choose to throw them both out, in which case the study shows you nothing very much. This is the Dutch early nutrition study. Again, similar size, 6 NICUs in Netherlands. They only gave the intervention to 10 days of age. Same study design, randomized to donor milk or preterm formula if there wasn't sufficient. Median 28 weeks, but look, mum's milk made up 85% of the total. Therefore, the amount of donor milk or the amount of formula milk they're getting is actually quite small. And again, over 100 of these babies only ever got 100% mum's milk. So they never got exposed to the intervention, right? So no difference in primary outcome and no difference in NEC when they look at NEC. So we've updated the Cochrane meta-analysis. This came out a few weeks ago. Some of these studies have important methodological challenges. The Lucas 1990 study, you'll see quoted over and over again, people telling you for 40 years we've known that formula milk increases the risk of NEC. That's what you're told. And the reference is the 1990 paper from Alan Lucas. Actually, that study was conducted in 1984, right? Neonatal care in 1984 and babies getting NEC and everything is totally different to what we have now. So you probably should say we should even just take this out of the meta-analysis now. Rick Shannon's study, 2005, it wasn't blinded, right? Where NEC is an outcome and you know that baby had donor milk or you know he had formula, I suspect you're more likely to say, oh, I think this is NEC, where you know he has formula. So that's also questionable. And then if you take those studies out, you're basically left with about 5 studies here. The Corpularian study, the Dutch nutrition study I showed you, the Cristofalo, this is a prolactor ready to feed, very small trial. We've got Luke Mill's study, which again is very small. And then we have just this US study and the Canadian study. So we really have not got anywhere near as many trials as you might imagine. And when we look at the funnel plot, we can see that there's a bit of asymmetry here. So we should be expecting some smaller studies here, apparently showing that donor milk increases the risk of NEC. That's what you would expect by chance. But these studies are missing, suggesting that people just don't publish the studies where donor milk doesn't look to be beneficial. Okay. So the Cochrane, good quality evidence, but we still need to be very skeptical. And then look at the total number of events here for NEC, 39 versus 66. 39 babies getting NEC in donor milk versus 66 in the preterm formula. It feels like it's different, right? But an extra 15 or 20 babies one way or the other would completely negate the meta-analysis. So we definitely need more evidence on how to use donor milk. As I say, we can see slower weight gain pretty consistent across the studies, slower head growth, but in the 2 studies that measured it, no impact on development at 2 years of age. So, as I say, we can conclude that short-term intervention may not make much difference. The meta-analysis is limited. We just need to keep asking ourselves the question, why does donor milk not have a beneficial impact on mortality if it's such a great thing for NEC? But if it's true that it does reduce NEC, NEC is a very expensive disease, and therefore the higher cost of donor milk would be probably offset by reducing NEC. So what about an exclusive human milk diet, right? You require human milk derived fortifiers. So I'm now going to show you the studies for that. So this is the Sullivan study, the classic 2010, I think it was published. 200 babies randomized to either getting donor milk or preterm formula if there was insufficient milk, and also randomized to getting a human milk versus a cow milk derived fortifier. And in the human milk, they had 2 groups, 100 versus 40. And this study showed quite a dramatic difference in the rate of NEC between those 2 arms. And they also showed a significant difference in surgical NEC, right? So I think that's a very powerful, strong finding. But note, this study was unblinded, was commercially sponsored. The primary outcome for this study that you would never know if you actually read the paper was actually difference in TPN days. And really, they should never have been allowed to publish the study in the way that they did, because they published it with the headline title, which was a secondary outcome. And that would not have been allowed in most high quality journals. Quite why it got through, I don't know. But as I say, it does show less NEC. However, a very high control rate of NEC, 11% in this group, to us feels a bit high. We did a similar design study, Janet, myself, and Chris in Newcastle, and Imperial also recruited some babies. Same study design, human milk or preterm formula, human milk derived or cow milk derived fortified. The primary outcome here was microbiome, but we saw no difference really in the microbiome in these babies, and we saw no difference in clinical outcomes. Without going through all the detail of it, basically that just shows you a spread out of all the data for all the bacteria. And whether you're on an exclusive human milk diet or one comparing or one using cow milk fortifier, they're pretty similar, which was surprising to us. We thought we would see a big difference. And when we dig into it, we actually see that the trial arm has a very limited impact on the microbiome. Actually, the biggest impacts on the microbiome were which NICU you came from and whether you were having probiotics. This is Deborah Connor's slightly smaller study using the human milk versus the cow milk derived fortifier. 120 babies, 27 weeks gestation. Primary outcome here was feeding interruption. Does cow milk fortifier make you have more occasions where you stop feeding? This was a blinded study, really hard to do, but they see no difference in time to 4 feeds or number of times you stop feeds, and no difference in NEC. So in the 120 babies, human milk versus cow milk appears to have no impact on NEC, but it's a small study. This has now been repeated in the Swedish N-Forte study, which was published this year. 220 babies, median 26 weeks, high-risk group, but Sweden, right? Very high rates of mother's milk. So donor milk use overall was tiny, 5 or 10%. The primary outcome was this kind of messy composite of NEC or sepsis or mortality. Same between the 2 groups, and absolutely no difference in NEC. So I think we can take from this that cow milk fortifier does not increase your risk of NEC. You'd expect that if you were avoiding it by giving human milk derived products, you would see a signal here, but there's no signal here at all. So my conclusion would be that using donor milk rather than formula appears to result in less NEC. There's no impact on brain development. The studies are small. The benefits of donor milk are probably more important where the mother rates are lower. Where you have high rates of mum's milk, it may be that donor milk really has very little benefit. But as I say, we know it's slow growth, and so many of these babies may need fortifiers. I think we can also conclude that using exclusive human milk diet using human milk derived fortifier actually has no impact on the microbiome. It has no obvious impact on neck. And if we really wanted to nail this question, we need to do a trial of about 2,500 babies, and nobody can afford to do that because human milk derived fortifier is incredibly expensive. And I would say we should look at the opportunity cost. If you really do have £1 million to spend on fortifier on your unit, you probably be better off spending it on lactation support and increasing the amount of mum's milk rather than on human milk derived fortifier. However, no evidence of harm, and there's a lot more still to learn. So I think we do need more data. I'm not saying we shouldn't research on human milk derived products, but we certainly don't have good justification for using them routinely, particularly given their expense. So just sort of segue out into thinking about societal impacts. You know, wet nursing has been around for a long time. We know that informal milk sharing may be much more common than we realize. And non-profit donor milk banks struggle for funding, struggle for supply. And although many people talk about commercially available human milk as donor milk, you have to remember it's not been donated. Right, the mothers have received remuneration, and we can spend a lot of time deciding how much remuneration is appropriate. And I think it's entirely appropriate to offer it. The mums are giving up their time, their choice to do it. But where do you set at that level? What would we feel is an appropriate amount that remunerated you without incentivizing you to do it? So industries are offering reimbursement. Could that be an incentive? How much is important? What about altruistic donors? If you're a mum living in current climate, hard up on benefit, and somebody said to you, look, I'll give you 50 quid a day if you sell me your breast milk, why wouldn't you do it? I would never judge any woman for doing that. And might they be tempted to perhaps stop breastfeeding their baby at 3 or 4 months and keep expressing to sell the milk? I can see why people who are hard up might do that. So I think this is starting to raise lots of issues about women's rights. And what I see in a lot of the qualitative literature is this desire of other mothers to help other mothers who are struggling in a very altruistic sense. And so women who are giving their milk to commercial sources for reimbursement may still feel they're doing a good thing. Why not? Working out how much all of this costs is really hard work. I know the Hearts Milk Bank Group have recently published a paper estimating the costs of donor milk. I think we can all agree that actually working out the true costs is impossible. We know the charges, but we will never know the true costs. But let's consider all of this in the light of what the economic cost is of having a baby with cerebral palsy or NEC. And as I said before, when we're thinking about costs, we should always think about the opportunity cost. If somebody is going to give you all this money, actually, would you choose to use it in this way? And this is why I'll never get invited back to Los Angeles business class again. Just look at the names that human milk derived companies use for their products. Human Advance or Advantage or something like this. Right? This name just wasn't chosen by chance. Neolacta, you know, new milk, you know, giving all these lovely ideas. And then what you see is the companies having international meetings. So this is the Investigator Award for Research in Human Milk Science. I mean, if I had that award, you might think, oh, that was great. But this is just set up by a company and they're awarding somebody else. And they run international conferences. So how would the public know whether this, I mean, how would anybody know who funded this or who funded one of their conferences? And they're very good at infiltrating, I think is the word I'm going to choose to use, parent-led support groups. And we'll see from a lot of parent support groups this, how dare you give my baby cow milk products when there's a human milk product there, right? So they fund these organizations as well. I have a lot of time for EFCNI, not digging EFCNI, they will take money. But let's not be foolish to think that they're not influencing people's behaviors. And they talk about the mothers as donors, but many of you would contest whether that's true donation if you're receiving reimbursement. And then you see the industry now will infiltrate the media. Tiniest premature babies fare worse with cow milk fortifiers. I think I've shown you data that says that's not true, right? But that doesn't stop people writing articles. You know that most of what you read in social media probably isn't true. But then they managed to get, big name people, professor, negative effects. And the public will see this, and the parents will see this, and their baby might have got neck, and they'll come to you and say, why did you not give me human milk derived fortifier? It's there. How dare you not give it to my baby? The trial that Janet led of another product, which is a powdered human milk fortifier, was identified as being contaminated with lead. So women who donate milk live in society. They walk out down that street in London, inhale all of that fog and smoke that you don't get in Newcastle, and then it all goes into their breast milk. So you can't control the behavior of women who are going to donate in the same way that you can control. You put a cow in a field, she's going to stay there. So we could have breast milk, and there have been studies showing actually heavy metal contamination of women living in certain countries. Okay. And now there's this absolute nightmare going on in the States where the payout against physicians and milk companies is astronomical. So 2 cases have been settled. The last one was settled for $90 million for 1 case of a baby who got NEC against a milk company for daring to provide preterm formula milk, where on the label, it didn't say this product might give you necrotizing enterocolitis. That's the contention. They're being told because they didn't put may give your baby NEC, they're at fault. And they've run 2 successful cases. There are 700 waiting to be heard. Right? Whose fault is that? Is it really the milk companies for saying might give you neck? Is it us for not telling parents, I need to give you baby formula, by the way, it might give you neck, but I have to give it? Who's winning out of this? Obviously the lawyers. And the amount of money is colossal. And it's not just fortifiers. There's all these other products now that are coming out. Cultured mammary cells. There's a company in the States where they will collect your mammary cells from your breast milk and try and now grow that and then produce your breast milk artificially in the lab. So this is potentially going to be a really big issue. And I haven't really got time to talk about the global aspects, and Gilly Weaver's here and other people here who can talk about this, but as a kind of global community, we still haven't got ourselves sorted out, what are the quality control, assurance standards, traceability, and all of this lot. And introducing this in resource poor settings is going to be very challenging. So we certainly need more trials. So I'm not saying commercial innovations are unethical. I think it is perfectly ethical, but society needs to be involved in it. We need to be aware of some of these issues like the Human Tissue Act. We might decide that efforts to help mums provide more of their own fresh breast milk is better than this. So we certainly need not-for-profit, nationally coordinated donor milk. And I started off talking to you about the importance of evolution in designing breast milk or the evolution of breast milk composition. And I often show this slide, which shows the 75 components regulated by the European Council on what has to be in formula milk. And then appearing here in color, you'll see all of the components that appear and have been identified in human milk. And I used to say, well, there are at least 350 separately characterized components or molecules in human milk. It's probably far greater than 350. It probably runs into the thousands and tens of thousands. But a whole range of products that you will never be able to provide in formula milk, and probably you won't be able to provide the same level in either donor milk or fortifiers. And endless potential research studies and stuff. Okay. So just to finish off, just to emphasize one other component in breast milk, which is stem cells. And so stem cells appear in breast milk in quite high quantities, and they either come from the mother's bloodline, so from immune cells or hematopoietic stem cells, or from within the breast itself, from the lactocytes and the muscle cells. And these stem cells go into the baby and then will traffic. And breast milk is absolutely stuffed full of cells. And so the estimate is that if you're breastfeeding, you receive about 10 billion cells a day, of which up to a third might actually be stem cells. And this figure on the right just shows you how they know these are stem cells because of cell surface markers that they identify. And stem cells only live for about 3 or 4 hours. So if you want to maximize the benefit of stem cells from mother's milk, you need to be trying to feed that milk whilst it's still warm. As soon as you put it in the fridge, those stem cells are dead. And so Xu Li's group in China or Taiwan, I can't remember, did a kind of pilot observational study, just seeing how many mums, and about half of the mums were unable to provide fresh milk. But about 100 were. They screened it. If you had a high CMV copy count, they didn't use the milk fresh, they froze it first. But where the mums had a low copy count, they used fresh mum's milk, and they intended to give at least 1 feed a day of warm breast milk. And in the next study, they're going to try and do it twice a day. And what they showed in the study was actually in the babies getting the warm, fresh breast milk, shorter days of PN, lower rates of NEC, lower rates of sepsis, lower rates of RIP, and lower rates of BPD. It's an observational study. But I think it does give us encouragement that this might be another thing about breast milk that we need to think about more. How do we get not just those few drops of buccal colostrum into the baby fresh, but how do we continue to make sure that every day we're giving fresh milk? How do we actually make that work when the mums are visiting and expressing? So personally, I would find it difficult now to use formula milk in the first week or 2 of life if there was donor milk available for a small baby. But I do agree we need more trials. We need better understanding of how to fortify products. I don't think there's good data to support an exclusive human milk diet. I think that small exposure to cow milk protein to me is fine. And the commercialization of this area, I think, is very challenging. I think it presents us with lots of ethical and regulatory issues. And I'm going to conclude with saying that I think the 2 key priorities really are how to maximize the availability of fresh mother's milk for sick and unborn babies, but then also how to protect human milk for national systems, the public, and not for profit. And I'm going to finish there. Thanks.
Thanks very much, Nick, for that. As always, a really excellent and thought-provoking talk. Could I ask all of our morning speakers to come back up the front, please? And if you could share one of the roving mics between you, and then Rax can rove with the other one. We've got some questions on the chat, which we will ask while people gather their thoughts to ask questions in the audience.
So I guess we have a couple of comments just going back, I think, to Christina's talk, the answers to psychological support being really important for mums and the impact of separation. It's more common than a question, separation of mom and baby. Then there's other comments on if we want to encourage expressing breast milk, then we need to invest in improving expressing environments and make it a more pleasant experience for mothers, which is a well-made point. Laura McCarricher makes a long comment about the Scottish Neonatal Q-based feeding learning event that they held last week. And as she's a long comment about nasogastric tubes and those being pulled out early in late preterm babies and potentially the negative impact on that. And anecdotally as a group, she says they thought it might be worth considering around 48 hours might help to set parental expectations and improve discharge breastfeeding rates, avoid disappointment. This was really goal setting for parents of the late preterm babies. And I think as a comment to Nick, then she also asks about whether we need an RCT. I think that relates to the donor milk. Lorna, if I'm wrong about that, come back in again. And her final comment is that should we be financially incentivizing mothers to breastfeed their own babies? And so, so you can take all of those bit by bit. And so she was born in France in the 1980s, and her dad was telling her that that happened to them. So I don't know, Nick, if we want to start.
Well, that has been tested in the UK probably about 10 years ago now in Sheffield, where they provided food vouchers to mums from more deprived localities, and could show that provision of food vouchers did incentivize mums to keep on breastfeeding a bit longer. And I would love to do that on neonatal unit. I've never been quite brave enough to start because I don't quite know where to start, because I think you need quite a lot of qualitative work to make sure that even starting to offer some incentive isn't seem to be offensive. So some people say, how dare you offer me an incentive to breastfeed? Why would I not want to breastfeed? So we need to be very careful of that. But you know, when you look at mums on an neonatal unit and you ask them to express 8 times a day, and it takes you 20 minutes to express and 20 minutes to clean your kit and store it and label your stuff, that's a huge time commitment. And if you then want to spend time with your baby, you're traveling to and from the hospital and you've got other kids to look after, I can see why time available to breastfeed gets squeezed. So I think it would be a great study for somebody to take on what level of incentive might appear useful. But yeah, I think that's worthy of exploration.
The comment about just providing food and drink as well is made, isn't it?
Absolutely.
So I don't know, Christina or even Chantal, to comment on the duration of nasogastric tubes, and are we better off with them in or out? Nice easy one.
I wouldn't put a time limit on it or have a guideline saying every baby should have this amount of an NG. I think it's got to be very Q based. It has to be what's appropriate for that baby and how they are doing. So I would definitely support having an NG tube in until that baby's adequately feeding. And seeing this weight drop when a baby starts going on to oral feed shouldn't be the norm. It should just be that we should be doing appropriate NG top up so that we're able to keep the baby growing, providing adequate nutrition and enabling them to progress to oral feed. So I couldn't put a time limit on it, but definitely support the use of NGs.
Any questions on the floor?
Have to say who you are.
Hi, I'm Brooke Davidson, and I've got a question for Nick, if that's okay. When you were looking at all your studies, how confident were you that the definition of NEC was clear and consistent? Or do you think that some of them were reporting suspected and some not? Because that changes everything.
Yeah, well, that's another study day, and we can have it tomorrow. No, you're right. I mean, of course, like definition of NEC is very suspect, but in a blinded study, you would expect that to be okay. So I think in blinded studies, you know, even if you're not quite happy with their definition of NEC, if there's a difference between the two groups, it's likely to be real. But that's the key problem with the unblinded studies. So in the donor milk trials, the Sullivan study, where they had the 2 arms, clearly was not blinded. Right, so very easy to overdiagnose NEC there if you wanted to. Rick Chandler's study wasn't blinded. Our study wasn't blinded. So if you get rid of the unblinded studies, you haven't got very much data, but the American study was blinded. But we only know for the American study what they called NEC, which is this classic stage 2 or 3 or greater or whatever. We don't actually know surgical NEC, and it's a shame because, you know, if there really was no difference in surgical NEC, I think that would be important. But still, even though we may disagree about whether it's NEC or not, it's still something, right? I mean, you're still stopping the feeds. So I would argue that even though you don't know that you're stopping, you know, really nasty necrotic bowel, anything that keeps a baby feeding and avoids PN and lines is probably a good thing. But you're right, it's a massive issue in all of these studies.
Over the back corner there.
Hi, I have a question for Nick as well. A situation that we often see in our neonatal unit is we have babies that are quite extreme or very preterm infants that don't have enough mom's milk around, and then we have to start them on donor, but then they obviously don't grow so well, and after around 2 weeks we're left with a dilemma because we don't use fortification routinely, do we now start to introduce preterm formula just to try and increase their weight gain? And inevitably, we might see increased NEC rates as a result of this sort of policy that we have. Would you recommend in units that don't routinely use fortifier, would you recommend that those units have a guideline in place to routinely fortify donor if there is a concern for growth, rather than having to use preterm formula?
Yeah, I mean, I don't see the point of giving donor milk if you're not also going to accept that you need to use fortifier, because the baby just isn't going to grow, and then you'll end up sticking it on formula. Whether you're better off being on formula or on fortified donor milk, I don't really know. And I think what people need to do is you need to go back and do all your calculations, because if you use the same amount of fortifier in mum's milk, which is often, say, 65 kcal, donor milk might often only be 40 or 45, and obviously lower protein as well. So if you are going to use donor milk and fortifier, you probably need to have some system for making sure that once the baby's had it for a few days and still isn't growing, you either add extra fortifier in or you use some protein hydrolysate or whatever. I think the other thing that people don't do is they don't give enough volume. We've all been indoctrinated, and Ari will tell us later on about the States, but it was like, if you go above that magic 160 number, the baby's going to die. And funny enough, the baby doesn't die. So we routinely feed at 175, but I'd be very happy to go up to 200, even 225. If the baby isn't spilling a lot, you get more mum's milk into the baby. So mainly the issue is you need to use fortifier routinely, I would say. But I think people also need to kind of just step back and say, actually, could we give the baby some more volume?
Probably got time for one more question at hand there, and then we'll close the coffee.
Hi, can you hear me? Is it on? Yeah. Just say thank you. They've all been fantastic presentations. It's just such a shame I haven't got a chance to ask everybody questions, but I'm afraid, Nick, it's you again. This spectre of this class action in the States and that amount that you just mentioned is horrifying.
Yeah.
But what worries me is so much of the data has intermingled and really sort of shadowed the question of fortifier versus formula. And what's happening is that they're being lumped together. And I think if that happens, and we're trying to feed babies human milk, and we're trying to optimize it, what do we do when people start saying, well, formula BMF is also a problem? And, you know, from my reading, say, of the Sullivan paper, only 2 of the babies actually were directly comparable with human milk versus bovine fortifier. All of the rest was muddied by formula. Christopher, they didn't even look at fortifier. It was formula. So how can we, you know,
well, I think the strongest evidence is that Swedish paper, which shows that you're tipping in cow milk fortifier, and there's no difference in the rate of NEC. I mean, it's not the biggest study in the world, but it's over 200, and it's small babies, and it's well done. So I think we can be reasonably reassured that as things stand, that cow milk fortifier does not appear to increase your risk of NEC. That may not convince everybody, but that's the best evidence we have. And at the end of the day, you can't just watch a baby not growing. I mean, you have to do something. The class action is not going to be replicated in the UK because the legal system is different, but the ramifications will impact on us. Parents are going to be seeing this. Parents are going to be saying, oh, I don't want this. You know, I don't want cow milk products either. I don't know where it's going to stop. I think what we're worried about at the minute is that the formula companies, whether you like them or loathe them, they provide a product without which we can't practice neonatal care. I suspect that some of those companies are just going to go, fine, we won't make anything called preterm. They don't actually make a lot of money out of the preterm market. They make the money out of when babies go home. I think there's a big risk that these big companies will go like, hang on, we're being sued for hundreds of millions. We're just not going to do it. And then the Americans will be left with term milk. I don't know what you're going to do then. Harold can tell us later on. No, no. And I've said for years, N3 should not make any statements because we want to be a group where we can mix and chat and argue or not argue. As soon as we start making statements, you expose yourself to legal action, right? So if you make a statement, you might be challenged on that. We haven't got any finances. And if a company wanted to shut us down, which is what they will do with other companies, the easiest way to shut you down is just to serve you with a legal writ, and then N3 is finished, right? Yep.
Very quick point, Janet, because we are very overrun.
It's very quick, but the point I want to make is that at the minute, any comparator of a bovine-based fortifier and a human milk-based fortifier compares a liquid human product with a powdered cow's-based product, thereby displacing maternal milk from the diet of the human arm. And it is still possible that there is a detrimental effect of cows-based fortifier, which is being balanced by the loss of some maternal milk from the current human arm trials.
Excellent point of which to close, I think. Thank you, Janet. Thanks everyone for the first session. There were more comments online, but in the interest of time, we are going to close the session.
We're going to come back at 25 past 11.
I was making notes on this.
I thought I might do.
Were you trying to stop them on the overrun?
Well, that was me when I
know.
I thought I really hate cutting.
I know.
And obviously, it's not like we're not doing abstracts here, are we? So
no.
So I just thought I'd give them a. We were running late, so we'd allowed to run, so 35 minutes, and that's all. Yeah, when they got to 35 minutes. And it also, and it didn't look like that. I didn't know it was a second to last time. Yeah. So, yeah, I gave them 5 minutes. I know. So, yeah, when they got 5 minutes over, I was like, I'm gonna have to say something. So, especially because you couldn't tell that it was, I had no idea how many slides.
Very impressed by your dedicated.
I had to keep my eye to super reminders. Take my little notebook away. Is it yours?
Yes, yours.
It's not my thing. Yeah, they all, but you can have it if you want, because I haven't read any more.
No, that's fine. You take it.
I did bring you, however, a treat or a Kit Kat. You get your Kit Kat. Did you crisp your treat to me? Really? Somebody got to buy you one. I stole them. Did you?
Do you want to introduce the first person and I'll do the second? The way around.
I'll do this one. I had to ask her what name was it. And then it's up there with the slide. Shall we kick off?
Yeah. Better look him up then.
That's what I know. Yeah, come on. Yeah, thank you.
No, I'm good, thanks.
Thank you. Okay. At that workshop, so I was thinking that, yeah. Okay. So thank you very much, everybody, for returning. And if you haven't returned, this is your last chance. We will lock the door and not allow you in. That's not true. So it's a great pleasure to introduce Amanda, who's an occupational therapist. So thank you very much for agreeing to talk, and we await with bated breath what you're going to tell us. Thank you.
Okay, well, thanks ever so much for inviting me. So I'm the ODN lead OT for Thames Valley and Wessex Neonatal Network, but I also work clinically in Swansea Bay. So my talk today is going to be a little bit different. I'm not talking about nutrition per se. I'm talking more on the practicalities of supporting support in feeding. So I'm going to run through the role of the OT in feeding. We're going to look at some stress management techniques to support expressing and producing breast milk, recognising stress or disengagement cues for feeding, the impact of the environment and the child's sensory processing on feeding, and I'm going to finish off with a case study. So first off, lots of people say, well, why do you need an OT to support in feeding? Surely that's the role of the speech therapist. Well, OTs work very closely with our speech therapy colleagues. The speech therapists focus more on safe swallow and the mechanics of feeding, whereas OTs focus more on cue-based feeding and the environmental and sensory aspects to feeding. So if you look at the RCOT, Neonatal Clinical Practice Guidelines that were published last year, it's recommended that OTs collaborate with the neonatal team to support parents in reading and responding to infant feeding readiness cues to promote the co-occupation of feeding in the neonatal unit and the following transition to home. And we also support parents and neonatal teams in providing an appropriate environment in the neonatal unit to enable parents and the infant to participate in early feeding experiences. And environmental support factors may include space, seating, privacy, the sensory environment and the NICU culture. So before I get on to feeding as such, I thought I'd talk a little bit about expressing, because a huge part of my role on the neonatal unit is supporting parents with stress management techniques. Because we know Bliss published a report 2 years ago that showed that 80% of parents that spend time on the neonatal unit report a decline in their mental health. And a lot of the time, parents on a neonatal unit are experiencing fight and flight responses. So this is an acute stress response, which results in physiological reaction in the body. And they're really, really unpleasant symptoms. It's usually triggered by an increase in heart rate, which then triggers a chain of reactions such as lightheadedness, feeling sick, sweating, trembling. All there is a protective system in the body that comes back from our caveman times when we had to fight wild animals for food. Well, now we don't need to do that anymore, but it's other more subtle events that cause stress in parents. And particularly for mothers, we've talked a lot this morning. I thought that was such a beautiful video by Sarah this morning, and she articulated really well how stressful it is for mums, the pressure they feel to produce milk for their babies, because it's vital for the health and well-being of their babies. So expressing frequently triggers this fight or flight response in mums. But the good news is that physiological response can be very easily reversed by simple breathing exercises, box breathing. If you get a mum to sit down in the chair and do those breathing exercises, it slows the heart rate. So as soon as you slow the heart rate, it stops that chain of really awful and unpleasant bodily reactions. Visualization is a really, really powerful technique. Because it's not really the actual act of expressing that's stressful for parents, it's the thoughts around it. So, for example, a couple of months ago, I was working with a mum on my unit in Swansea, and she had a diagnosis of ASD. And at the ward round that morning, it had been discussed with the parent to exclusively breastfeed her baby. I came along, first thing she said to me was, Amanda, I'm not going to produce enough milk, my baby's going to die. So she was in an extreme state of stress. So I said, right, let's sit down. So I put her in a chair, sat down, got her comfortable. We did some breathing exercises, and then I got her to express, and I talked her through a visualization technique. Now, I live and work in Swansea. When I ask parents, what's your happy place? Most parents say next to the beach. So this is my shameless plug of a beautiful beach opposite our neonatal unit in Swansea. And I just talked her through, the feeling of the sun on her back, the sound of the waves, the feel of the sand. And as she sat there, she produced 2 bottles of milk like that. So, sometimes it's the simple things that are overlooked. I loved Nick's talk, and when he was talking about the, the cost about donor milk, I thought, well, maybe neonatal units could save money by having lactation support and more OTs on the unit to do more of this work. Yeah, and another really nice technique is progressive muscle relaxation, where you help parents to work through the major muscles in the body. That's a really nice way of reducing stress. So thinking about observations that I do on the unit, so most occupational therapists use this synaptic theory of development as a framework for understanding the behaviour of preterm babies. Now, I assume most of you will know the work of Heidi South. She was a neuropsychologist who developed the NIDCAP model of developmental care. And this is a really nice framework for understanding preterm behaviour. And it's a systems view of the baby, with describing the infants, babies, grouping them into these sort of 4 subsystems. And although these subsystems are represented hierarchically in this diagram, you can't really separate that out because they're interacting the whole time. So if you look at a preterm baby, there's huge amounts of instability in these systems. And in order to reach a point where a baby can really sort of self-regulate and pay attention, they need to gain mastery over all these subsystems. So as a baby gets nearer to term, they generally have more stability in these systems. But then, of course, we expect a little bit more of the baby. So we ask them to pay attention. We ask them to sac feed. And you can very quickly see these systems unravel. So if you observe a preterm baby, especially the early preterms, when they're first learning to feed, they might show all the readiness cues for feeding. So they might be awake and alert and ready to feed. But once they start feeding, these things can change quite quickly. Their state can change. They can go quickly from a quiet alert state to drowsy or into shutdown. Their motor system, when they're trying to coordinate their suck, swallow, breathe, they lose their tone, they go really floppy, and then that's really sort of unsettling, destabilizing for the baby. The heart rate, the breathing sort of can increase. And all of that overloads the babies, because lots of these babies, their nervous system and brain isn't fully developed, and they're in an environment where they're overwhelmed by multiple sensory inputs, which is hugely challenging for them. This is one of my absolute gurus, Dr. Brazelton. Practically everything I do on the neonatal unit, I have learnt from his teachings. Because even as recent as the late 70s, we believed that babies were passive little beings, that we did things to babies, but they didn't really impact on us. And he was one of the first paediatricians to say, actually, babies are talking to us from day one. They don't have their words, but their behavior is their language. And that is something that you can trust. So a big part of my role is education, not just to parents, but the rest of the neonatal team, on understanding a baby's behavioural cues. And this is super, super important for successful feeding. So babies will show generally approach and avoidance cues. So in order to be ready to feed, they need to be calm, relaxed, they need to be in a flex position, and they need to be alert and ready for the feed. So you can achieve that and start the feeding, but then if you observe the baby through the feed, especially when they're first learning to feed, they will very quickly show avoidance or disengagement cues where they're beginning to struggle. And why is it really important to look at these cues? It's because we've moved away in recent years, I'm glad to say, from a traditional volume-based approach to cue-based feeding, because we know that 40% of babies on a neonatal unit experience feeding difficulties. If you look at the feeding clinics in the community, about half of those babies that present with aversions and difficulties are preterm. So feeding needs to be the most important thing for a successful feeding. It needs to be pleasurable for the baby. So it's not about the amount that we can get into them. It's enabling them to have a positive experience of feeding. So this is why we need to really, really closely watch signs of disengagement. And I think because a lot of these behaviours, because we see these behaviours all the time on the neonatal unit, as human beings, we habituate to it, and people forget that these are signs that the baby is telling you they're struggling. I was working with an ex-24-weeker. I was watching a feed, and he was alert and ready for his feed. And his mum was bottle feeding him. And he started off great, and then he took a few secs, he started spitting up, he started coughing, his state went like that, he had eye floating and lost his alertness really quickly. And I said, oh, we need to stop the feed and give him a tube top up. And his nurse came along, and when I explained what I'd observed, she said, oh, he always feeds like that. But that's not good enough. He shouldn't feed like that, and that's unpleasant. That is going to lead to aversions later on. So really, really important. And you can look at cues using a traffic light system. So obviously regular breathing and all the approach cues that I described earlier. You're good to go. If you start seeing the stop hands, extended limbs, grimacing, yawns, hiccups, maybe a pause in the feeding. If you get to the point where you see loss of tone, eye floating, mouth hanging open, and babies are really, really pale, then you need to stop the feed and give them a tube top up. So as well as behavioural cues, behavioural states are really, really important for feeding. So at any point in time, a baby is going to be in one of these behavioural states. So you've got deep sleep, where you see regular breathing, eyes closed, very little spontaneous movement. And deep sleep is really important for growth, because when babies are in a deep sleep, they produce growth hormone. So the best way you're going to help a baby achieve deep sleep is skin to skin on the mother. Light sleeps, when eyes are closed, you can see the rapid eye movements underneath the eyelids, and there's low activity levels, maybe the occasional sucking movements. But light sleep is super important, because when they're in this state, that's when all the synaptic connections are firing and being wired in the brain. So light sleep is super important for brain development. Drowsy is just a transitional state when babies are either transitioning into an alert state or vice versa, going into a sleep state. Quite alert, the important state, babies aren't going to feed well unless they're in that alert state. Then you have active, alert, and crying, fussing and crying that speaks for itself. So positioning a baby is also crucially important for successful feeding. Babies feel organised when they're in that flexed posture. And preterm babies, especially the earlier they've been born, they don't have the muscle strength to get themselves into those positions. And particularly with feeding, because the baby is putting all their efforts into trying to coordinate their suck, swallow, breathe, they can't manage their posture. So we need to do that for them, so we can support parents in holding them in a flex position. Lots of mums have said to me, oh, my baby's waking up for feeds, they're feeding really well for 5 minutes, they've fallen asleep, I don't know what to do. Swaddling a baby, I know swaddling got lots of bad press a few years ago, and we don't recommend swaddling to sleep. But actually swaddling helps a baby to achieve a quiet alert state, because it brings them into flexion, it sorts their posture for them, so they don't have to worry about that. They don't need to multitask, they can put all their efforts into feeding. It's really, really important for bottle feeding as well. And somebody mentioned this morning about elevated side lying. If you've got babies with tone issues, or if they are really quite disorganized in their feeding, elevated side lying not only gets them into a really strong flex posture, but it also, if they're not coordinating the swallow of the milk, then it'll just dribble out the side. So it's a much safer way of feeding a baby. I hate seeing this. Hopefully we don't see it very much on neonatal units. And this mum wasn't feeding her baby. I asked her to do it purely just to put in none of my babies would feed this way. Because again, if you've got an X 24, 25 weeker that don't have the muscle tone, they are not going to manage their posture in this position. And also, we've talked a lot about the importance of feeding being a pleasurable experience for the baby. If you've got a bottle in a baby's mouth and you've got their hand behind their head, they can't pull away. They can't show you when they need a pause or when they need a little break. So it's really not good. The reasons behind it were positive. Nurses were trained years ago to observe these cues and to observe the babies, and they just thought that was the best way of doing it. But anyway, we don't do that anymore. So as well as all these other behavioural cues, environment is crucially important. If we want parents to successfully feed, they need to be comfortable. So we need to have chairs. We need to have reclining chairs next to the cots. We need footstools. We need pillows. And the environmental impact has a huge impact on the baby's ability to sustain their state to feed successfully. So if the lights are too bright, a preterm baby will find that really challenging and might go into shutdown. Similarly, if the unit is really noisy, it's too much, baby gets overloaded, they say this is too much, I'm tapping out, I'm going into shutdown. So all of these things we really need to consider. So I'll just talk through a case study that I did about a year ago. So I was working with a mother of twins. Oh, there's a slight mistake on this. They weren't born at 28 weeks, they were 30-week twins. MCDA, spontaneous vaginal delivery. Twin 1 was 1,509 grams, twin 2 was 1,490. They had a really unremarkable course. They were sailed through really quite straightforward babies. And they got to 37 weeks corrected. Mum was rooming in, trying to establish breastfeeding. Twin 1 was fully breastfeeding. Twin 2 was having a much tougher time. She was only managing 1 breastfeed a day on average, and was needing lots of NG feeds. She'd wake for her feed, but she'd fall asleep quite quickly. So I popped my head in the room to speak to Mum one day, and she was absolutely at her wit's end. She had a little 18-month-old at home already. She'd had 7 weeks in hospital. It had been a lot of juggling. It was really, really stressful. And she was like, I'm going out of my mind. I don't know what to do. I really need to get home, but I just can't get my baby to feed. So I thought, right, what can we do? So my first thought was to carry out a Brazelton newborn behavioural observation. So for those of you that aren't familiar with that tool, it's a neurobehavioural assessment which looks at an infant's regulatory abilities, what they can manage, what they can cope with, and if they have any challenges. So we did this with this baby, and it became really obvious straight away that she was unable to produce an adaptive response when presenting with multiple sensory inputs at the same time. So for example, so the first part of the observation, you put the baby in different positions and you watch their responses. And I noticed that if I handled the baby and spoke to her at the same time, she was showing lots of stress cues. It's also very sensitive to the environment, particularly overstimulated by bright lighting. There's one part of the observation where you hold the baby and you move your head really slowly from side to side, see if they can fix and follow. As soon as I held her in that position, she was showing stress cues, she was squirming, she was looking away, not managing at all. So I said to Mum, can we turn the lights off? So we turned the lights down, put a dim lamp on. This baby's eyes pinged open, she's happy, she's engaged. I could do the rest of the observation. So talking this through with parents at the end, swaddling and dimming lights enabled the baby to achieve a nice quiet alert state for optimum feeding. And parents, Mum talked about her usual approach, and she said she'd been feeding the baby, she'd been putting lights on to try and keep the baby awake for longer, and she was stroking the baby's cheek and talking to her all at the same time. And that was obviously really overloading the baby, and she was just going into shutdown. So the outcome from this was that mum then stopped doing all of that. She fed the baby in dim lighting. She just concentrated on feeding. She swaddled her. She didn't stroke. She didn't talk, just fed the baby. And within 24 hours, that baby was exclusively breastfeeding. I came on the unit the next day. The mum nearly knocked me over. She gave me a big hug and said, "Oh my gosh, you've revolutionized my feeding." So really, really great outcome from some really simple strategies. We improved the infant's occupational performance. We reduced the sensory-based feeding issues. There was a significant reduction in stress for the parents. The mum was a different person altogether. Improved her well-being and reduced length of stay because they were discharged the very next day. And most importantly, parents were really empowered and confident in supporting the infant's continued development once they were at home. And that's it. So thank you for listening. Flew through that. Oh, I forgot. I was mic'd up.
Thank you for inviting me to talk about this. Now, I always put this slide in when I'm speaking to an audience that's very neonatal based, that I am not a neonatologist. Probably everyone in this room manages metabolic bone disease prematurity more often than I do. And I kind of come with it with an approach looking at the physiology of bone mineral metabolism, which is kind of more where my expertise lies. But you guys kind of have more on the shop floor experience. So I'm going to talk about why metabolic bone disease of prematurity happens. And I always kind of talk about what normal calcium and phosphate physiology is to help us understand why it happens and where the problems lie. And then I'm actually going to talk a bit about the BAPM framework that we've been developing this year and some of the key messages from that, and give a bit of a sneak peek on what's going to be in there. And then spend a little bit of time at the end talking about why this is important in terms of short term, but more so in terms of some of the long-term outcomes. And then highlight some of the gaps in the evidence that will hopefully form kind of a future research agenda for people perhaps in this room. So it's important to recognize the terminology. Metabolic bone disease of prematurity essentially means just an undermineralization of the preterm skeleton. And there are different terms in the literature. There's osteopenia of prematurity, which is more a radiological diagnosis referring to a washed out appearance on the radiographs. And this is very subjective, even between radiologists. And the kind of studies from the 80s have shown that you need about 30% bone loss before you can appreciate any osteopenia. And then there's rickets of prematurity, which is more a biochemical diagnosis, characterized by a low phosphate. And regardless of the type of rickets that you have throughout life, the kind of key feature is low phosphate, whether that's because of a calcium deficiency, vitamin D deficiency, phosphate wasting. And this is typically in rickets comes with a high alkaline phosphatase as your bones turn over to try and mineralize better, with or without an elevated PTH, depending on whether or not you've got calcium deficiency underlying this. And this comes with its own kind of radiological features. So you get the cupping, fraying, and widening of the metaphyses. This also shows the osteopenia that we've talked about. And in this infant, you can see the periosteal reaction or periosteal cloaking, which is more specific of hyperparathyroidism. So why does it occur? So initially, I used to kind of focus on it being a deficiency of calcium and phosphorus, which are the two main bone minerals that are kind of incorporated into the bone. But over time, I think I've come to realize with dealing with more cases that in the extremely preterm infants, or those that have other kind of nutritional issues, it's also an issue of incomplete ossification. So the protein scaffolding into which the minerals are incorporated can also be an issue in the extremely preterm infants. So it's not only just the mineralization of calcium and phosphate, but also the deposition of the osteoid itself that in the extremely preterm infants I'm sensing is an issue, and therefore kind of good protein management is also important. And it happens because 4/5 of the bone mineral accrual that happens in infants in utero occurs in the 3rd trimester. So if you're born preterm, you're going to miss out on 80% of that bone mineral accrual. And combined with the fact that it is a period of rapid bone growth, and so you're needing much more calcium and phosphorus to incorporate into more bone. Add to that the fact that despite improvements in postnatal feeding regimes across the decades, it still can never replicate what the placenta is going to provide in utero, and then add to that some risk factors, which I'll talk about in a moment. So if we just step aside and think about the physiology, when any child, including preterm infants, have a primarily calcium deficiency, there's 2 main hormones that are important. One is the active form of vitamin D, which is 1,25-dihydroxyvitamin D. And this is formed from 25-hydroxyvitamin D, which is your body store of vitamin D. It's 1-alpha hydroxylated in the kidneys to give the active vitamin D. And that acts on the gut to increase both calcium and phosphorus absorption. And then the other key hormone is parathyroid hormone. So PTH has 3 effects. One, it increases the activity and production of 1-alpha hydroxylase so that you make more active vitamin D and more calcium and phosphorus absorption. It also acts on the bones to get calcium and phosphorus from there, so that you get the demineralization that's typical of metabolic bone disease of prematurity. Now, both of these increases both the calcium and phosphorus absorption into the blood. And if it was just left at that, the calcium and phosphorus would bind and you wouldn't actually improve the calcium deficiency. But in the kidneys, you have calcium reabsorption, but an excretion of phosphorus, so that in calcium deficiency, the PTH maintains your blood calcium levels at the expense of phosphate, which is why you have low phosphate biochemically, but a normal calcium because of a hyperparathyroidism. And then as with most kind of endocrine organs, there's a feedback loop via the calcium sensing receptor in the parathyroid gland to make sure that the calcium levels are kept in homeostasis. On the other hand, when you've got a primarily phosphate deficiency, your absorption of phosphate from the gut is mainly passive with a little role of the active vitamin D. But actually most of your phosphate balance is determined by excretion through the kidneys by FGF23 and PTH. But the important thing is that there's no phosphate sensor in the parathyroid gland, and usually it responds to changes in calcium secondarily. And so if you've just got a phosphate deficiency or phosphate wasting without any calcium deficiency, the PTH will be normal. I would argue, I have no evidence for this, but I would argue that it's possibly less likely in the preterm neonate, because there's been stuff shown from the 80s that the absorption of phosphorus is much better than the absorption of calcium in the preterm gut. So I'd approached BAPM to see if we can establish a framework on metabolic bone disease of prematurity. There's quite a variety in practice, and to see if we can harmonize broad practice across the UK, ideally based on best available evidence, but I'm sure you'll know that there are quite a lot of evidence gaps, and so to do it based on consensus where there is a gap in evidence. And we graded the literature as well as the recommendations based on the literature, and this will be coming out soon. So the working group was a combination to try and cover all the different people that would be important in managing metabolic bone disease of prematurity. So through BAPM, we had neonatal consultants, trainees, ANNPs, and a physiotherapist. Through the neonatal dietetic interest group, we had dietitians, neonatal pharmacists through NPPG, it was important to have a biochemist, and I'll come on to kind of some of the work that she looked into, as well as a pediatric endocrinologist, and a parent, primarily actually because we've developed as part of this a parent information sheet so that they understand why we're doing all these blood tests, why we're so focused on these things. So we've started in January, it's become a bit delayed. It'll be due out for consultation shortly. So those that are BAPM members, please do comment and feedback. So if we talk about prevention, we looked at the risk factors, and there's extremely good evidence when it comes to birth weight and gestational age, particularly birth weight. It comes out often as one of the strongest factors. And actually a lot of the papers looked at not just birth weight, but whether they were small for gestational age. And again, that's a risk factor, I think, speaking to the fact that low birth weight is not just because of its association with prematurity, but also probably some placental insufficiency in utero as well. This is a meta-analysis that's been done recently that again highlighted how important birth weight and gestation are. And it also highlighted quite strongly the importance of the duration of parenteral nutrition. I'm sure you'll all know that's because of limitations in how much calcium and phosphate we can get into it, with a cutoff with most studies being greater than 4 weeks. There was low to moderate grade evidence for the use of diuretics and for the use of steroids. We kind of discussed within the working group a bit about how we would define steroids, because lots of children will have this, and we kind of came upon the use of prolonged, i.e. more than 2 weeks, or recurrent use of steroids. And at present, there's insufficient evidence to comment on ranitidine or caffeine as a risk factor, although there are some papers for this, or for NEC and chronic lung disease, because they kind of associate with prolonged use of PN and use of diuretics and steroids as confounders. So then we looked at how we can optimize nutrition. I'm not going to spend too long on this because I'm sure this audience already knows more than I do about this. And there's, again, very strong evidence to support the use of fortification and breast milk. And if you can't use breast milk, then preterm specific milk formulas. We've talked about the molar ratio of about 1.3 to 1 between calcium and phosphate, not only enterally, but where prolonged PN is required to enable optimal absorption and utilization of these minerals, commenting on the fact that it depends on stability and provision, recognizing the fact that not all units are able to kind of adjust the PN ratios, and to give vitamin D supplementation between 400 to 1,000 units daily. So this is just one of the slides that I typically use, just again to highlight how much of a difference there is in calcium and phosphorus content between unfortified EBM compared to fortified EBM or preterm formulae. And that's in line with the recommendations both in America and in Europe. I've already mentioned the importance of the calcium phosphorus ratio, and that's on a kind of millimole basis. I know that's created some confusion in the past because the paper talks about 1.5 to 1.7, which is on a milligram to milligram basis, to make sure that you're absorbing both at an optimal rate. And vitamin D is recommended, although the evidence is unclear. Work from Oxford has shown that about 90% of preterm or very low birth weight infants were vitamin D insufficient or deficient, and not all of them necessarily developed a metabolic bone disease of prematurity. So the jury's out about its importance, but in the absence of harm, it's important to optimize. And then we talked a bit about handling to try and minimize the complications of those infants that may have metabolic bone disease of prematurity. And this is all stuff that you guys will be much more aware of than I am in terms of adequate positioning and handling of infants, splayed hands, etc. Nesting to allow them to kind of move their limbs against a barrier to help develop muscle strength. The importance of doing nappy changes and dressing correctly where you're not pulling on limbs, pulling on legs. Because we have, I'm sure, across all of us seen fractures on routine neonatal handling. And these kind of things are important for the baby, and utilization of second procedure if needed, particularly for medical procedures. And this is actually a big focus on the parent information sheet because the feedback was that they often are a little anxious in how to handle these babies when they've been told that these infants have weak bones. And then we looked at the evidence for passive kind of physical therapy regimes. And this is based on the mechanostat theory from the 90s, showing that the biggest determinant of bone adaptation and bone strength is the muscle forces that are imparted on it. And this is true with the neonatal domain as well, where the muscle forces are what causes bone deformation and the mechanosensors and the osteocytes to then adapt accordingly. And there have been a few systematic reviews of this, and obviously lots more studies besides. And the general trend is an improvement in the bone turnover markers, which we don't tend to use in clinical practice. I'm not talking about ALP, which is more a mineralization marker, but also improvement short-term in bone density. But there's no data on some of the kind of clinical markers that we would use in clinical practice, nor on long-term bone density, nor on fracture rates. And so currently we kind of said not to advise it as, and I wasn't aware of this until the working group, that it potentially disrupts kind of neurodevelopment by interrupting routine kind of neonatal care with passive physical therapies. But I think this is probably an area that's going to develop as more studies come through. Then we moved on to screening. In terms of timing, there's no great data. This is a paper from 2017 that showed that kind of changes initially happen at about 2 to 3 weeks of age with phosphate, with an ALP lagging at about 4 to 5 weeks. No data on PTH. And we were quite clear that the important thing is to start screening, ideally once enteral nutrition is optimized, because otherwise you're kind of starting supplementation, etc., without addressing core issues with making sure that the feeding is at its optimal for adequate bone health, except if you're receiving long-term PN, in which case it'll take ages before you've adequately established enteral nutrition. And in the absence of evidence, we've said fortnightly, but that's very much a consensus. So in terms of the biochemistry, I think the important takeaway message is that you need to understand what your local assay is and what your reference range is for your local assay, because they will vary based on the different commercial assays available, but also appreciating the deficiencies in some of the reference ranges. So in the ALP, we've put a cutoff of 650 because the kind of the best study that's out there, which is of moderate quality, suggests that an ALP cutoff of 650 has greater sensitivity and specificity for kind of bone density. The phosphate, we've just said less than 1.8, but it really does depend on what your reference range is. But bear in mind that reference ranges vary massively for phosphate based on age. And so just have that discussion with the lab. And I suppose the one big change for me is the PTH range, PTH cutoff that we're saying. So I have previously talked about the fact that the PTH cutoff and calcium homeostasis is very tightly regulated. And so in children, in adults, the normal PTH is, I mean, give or take the assay, is normally about 7 picomoles per liter. And I've always said that. And actually, there's been this study out, and there was a small paper by the same authors in 2019 that supported that. They've done a much bigger study now that's come out that suggests that actually the PTH reference range in preterm infants actually goes higher than what we'd appreciated. Why? I don't know, but that's a big change, at least from my practice and my advice, to increase the cutoff of PTH. Again, the Oxford group, and it's not been published yet, have already implemented that. So they were clearly ahead of the curve, and they've shown no difference in outcomes in metabolic bone disease of prematurity and less hypercalcemia. I think the evidence is clear that if you combine the markers, you get greater accuracy. Vitamin D shouldn't be used as a screening tool, just following diagnosis and optimization as needed. And there's insufficient evidence at present for urinary markers, particularly for phosphate wasting, as well as calcium itself, because I've already explained that the PTH will kind of make the calcium normal most of the time. In terms of radiology, the short answer is there's not enough evidence to recommend in clinical use any screening with radiographs. Bone density scans, which some would argue is the gold standard, I think clinically is not really practical. And quantitative ultrasound, I don't know of many units that use that now. It was used quite a lot as a research tool in the past. But I think we've mentioned about reviewing any radiographs that may have been taken. These children will have chest x-rays, etc., that may further support the diagnosis of metabolic bone disease of prematurity. So this is one that actually was looked at retrospectively because they came through via the safeguarding route to general pediatrics. This is an X28 weeker recently in our unit or in a local hospital that was discharged, came in for bronchiolitis and was noted to have rib fractures. But actually, when you look back, even on the neonatal unit, you can see this rib fracture that was there whilst they were on the neonatal unit. You can see the splaying and fraying of the metaphyses here in keeping with metabolic bone disease of prematurity, and also callus formation of previous rib fractures. This child did have biochemical evidence of metabolic bone disease of prematurity and was on calcium supplements, but probably we didn't appreciate whilst they were on the neonatal unit just how significant it was radiologically. So the treatment we've divided into two arms, like a relative phosphopenic state and a relative calcipenic state. So phosphopenia is a low phosphate and or a high alkaline phosphatase, but with a normal PTH. So those that are enterally fed, we've said to give phosphate supplementation. And I've said in 4 divided doses, the more you can divide it, the better. The BNF says, I think, only 2 or 3, but the more doses you can divide it across, the better, because then the secondary hyperparathyroidism that you get with phosphate supplementation is lessened if you give smaller doses more frequently. But to maintain this, the calcium to phosphate ratio, we suggest giving calcium supplementation. Also, practically separate to each other and separate to the feeds, although I appreciate that that's difficult in practice. And if you're PN dependent, to try and increase the phosphate content by 0.5 millimoles per kilo per day. This is, again, just a number that is consensus. There's no evidence base to this, while still adjusting the calcium to maintain a ratio of at least 1 to 1. And in a calcipenic state, so the main difference here is elevated PTH as per the 10 picomoles per liter cutoff that we've discussed. You would stop the phosphate supplements and start calcium supplementation and try and increase the calcium to phosphate ratio in PN. Again, we've put in there if possible because it depends and it varies from unit to unit. So people have mentioned about the ratio in the calcipenic state. And I think from a physiological point of view, maintaining that ratio is less relevant in view of the hyperparathyroidism that is already kind of tipping the balance in terms of calcium deficient state that you need to overcome. And so that's why we don't advise concurrent phosphate supplementation in a calcium deficient state. So this is a slide from previously that shows why phosphate supplementation in calcium deficiency doesn't work. And there have been reports case reports that have been published from India about this as well. So when your ionized calcium is low, your PTH is high, which causes the bone resorption and osteopenia and the phosphate wasting in rickets. And if you just act on the low phosphate and give phosphate supplementation, you just drive this hyperparathyroidism and the metabolic bone disease of prematurity. So it was quite obvious from the working group that people wanted some advice on monitoring after you start supplementation. So this is what we've come up with. This is not evidence-based either. There's no suggestion on how to do it. This is just based on kind of rationale. So we would suggest fortnightly measurement of phosphate, PTH, and ALP. I've put it in brackets because we know that that lags, and that's kind of been shown in the previous slides where the ALP starts rising later than the phosphate. And then we've divided it into responders, where you have normalization of biochemistry, and you start halving supplementation until you reach less than 0.5 millimoles per kilo per day, and then you stop. Some units do just consider trial off treatment when you're almost term corrected. I don't know the outcomes of that because I've not personally done that, but other units from the working group did do that, and that seemed to work well for them. Or non-responders where the biochemistry is not getting better or is worsening. So in those where the PTH is going up, you can increase the calcium up to a maximum of 3. If the PTH is normal, we can increase the phosphate as well as the calcium. And then we've kind of highlighted when to discuss with specialists, whether it be pediatric endocrine or pediatric metabolic bone disease specialists, if you're on maximal dosing and you're still not getting a response, to check that there aren't any other factors at play that haven't been understood. There's quite a lot of papers actually, and I hadn't realized this because I was the one that did the literature search on this with regards to vitamin D treatment. I hadn't realized just how many there were. And so for vitamin D deficiency, our advice is, as per kind of most standards, that we aim for a 25-hydroxyvitamin D above 50. That's just based on consensus standards. There is one paper that suggests that your other bone biochemistry is optimized when you're above about 80 to 90, but we thought 50 was probably more achievable. And if you're deficient, to give vitamin D supplementation of 1,000 units daily, which includes the multivitamins. Lots of papers comparing 400 to 800, 1,000, 1,600. And so on balance, 1,000 seemed like the best in terms of achieving better outcomes faster, because the ones that are given 400 units can take 2 to 3 months before their vitamin D is optimized. And then monitoring no more frequently than 6 to 12 weekly, because it takes time to kind of replenish the vitamin D stores. And there may be cases where higher doses or intramuscular dosing may be needed, especially if absorption is an issue. And once you've achieved vitamin D above 50, to then just go on to a maintenance dose of 400 units, which will usually be provided by the multivitamins. So I just wanted to talk briefly on why this is important. There's evidence to show that it worsens respiratory outcomes, even whilst on the neonatal unit. And most importantly, untreated, it can lead to fragility or pathological fractures just on routine handling, typically of the long bones and the ribs, which can cause kind of swelling, deformity, and more importantly for the child, pain on handling. And we have been involved in quite a few cases where it raises safeguarding concerns, particularly if it happens after discharge, and if the metabolic bone disease of prematurity hasn't been monitored. So this is one that we had recently, which is a 30-weeker who came in with bronchiolitis and was noted to have this rib fracture at about 4 months of age. We looked back, and the chest x-rays that were done on the unit didn't show this rib fracture. And on the whole, and thankfully the biochemistry had been monitored, which had been completely normal throughout, which would suggest that actually this isn't metabolic bone disease of prematurity, even though you would argue they were at a gestation where they could have had metabolic bone disease of prematurity and they had chronic lung disease. But we could argue that actually this is more likely to have sadly been inflicted, particularly because the twin then came in as part of the safeguarding processes and also had rib fractures. So the long-term consequences are still as yet unclear. There's conflicting data on whether it eventually leads to reduced bone mineral content and density at term corrected. There is fairly good data, depending on the cutoffs that you use, about an impact on long-term growth based on ALP levels. But what's unclear is whether this actually affects fractures in the long term. And actually, that's what this is most important when you're thinking of metabolic bone disease of prematurity. Does it weaken bones in the long term and increase fracture risk? But this is just the last slide that kind of talks about some of the gaps that I think and others in the working group thought were important to address for future work. One, like I've just mentioned, the short and long-term outcomes, particularly fractures, to kind of determine how important this condition is in the long term. Again, we've mentioned about the passive physical activity regimes with hopefully more useful outcome measures. When screening should be done, and this is quite challenging as you need to do quite a large natural history study and ideally stratify by gestational age and birth weight. A bit more work to kind of identify optimal biochemical cutoffs, both for screening and for diagnosis. And I think one thing that I don't fully understand is why some children become phosphopenec. given how well you absorb phosphorus through the gut, is it because of a deficiency in dietary phosphorus, or is it because of phosphate wasting because of immature kidneys? But that's been argued against in the past as well. And I think urinary markers in that sense would help within a research setting to establish that. And finally, optimal enteral treatment regimens and the kind of correct ratios. We've got data from the 80s, but whether that still applies when you're talking about supplementations, and how much, if any, the role that vitamin D has in a preterm's bone health. That's everything. Thank you for listening. Again, just a quick plug, when it does come out, for those that are BAPM members, if you can feedback on the framework, that would be really useful for us. Thank you. So I didn't go into it, but we've talked about using donor milk as a secondary thing if mother's own milk is a supply issue, and then using preterm formula. But that's not kind of a strong recommendation. I think that's just based on consensus and other guidance out there with using. Sorry, donor milk. Did you say donor? Yes, the question is, would you advocate fortified? Yeah, I think we have in the guide, in the framework.
The next question is, what is the rationale for treating vitamin D level? What's the rationale for treating vitamin D level 24 and above, but less than 50?
I suppose the short answer is there's not much rationale. Well, if you look at the data, it's unclear as to whether it actually makes any difference in metabolic bone disease of prematurity or in long-term bone health. We're just using it as a cutoff kind of based on consensus, and that's not just consensus amongst us, that consensus amongst other documents as well, because theoretically it should optimize your bone health, it should optimize your kind of calcium and phosphorus absorption by improving vitamin D stores. And it's very clear that it does not cause any harm by optimizing beyond that. So in the absence of harm and the theoretical benefit, that's the kind of rationale that we're working on.
The other question that came is for you, Amanda. Not for the talk, by the way. What do you think about birthing babies in the sitting position next support? So question birthing.
I'm much more of a fan of the cycle leg approach than sitting. And what I would do is, if I was burping a baby, I'd put the baby over my shoulder rather than have him in that sitting position. You know, it's fine for term babies, but preterm babies, you can support them in much better ways than that. Interesting question.
I've got a different microphone now, so hopefully they can hear me reading the questions. Although for those in the chat online, all the questions have been the ones in the chat. But now I've run out of questions in the chat. So anyone got any questions from the audience? I'm going to have to take this microphone to you. Ilana.
Hi, Amish.
Hi,
it's Ilana from Oxford. So as you know, we have looked very deeply into the data, the biochemical data after changing the guideline. And one thing that I think we've uncovered, which we kind of perhaps wish we hadn't, is the rate of PTH suppression. And so in our new iteration, we are recommending checking urine calcium creatinine ratio if the PTH is suppressed and the calcium is high. And what we found is that we're finding a lot of really high calcium in the urine in babies that aren't on calcium supplements. So the too much calcium is coming from the fortifier. And this is definitely upsetting us because we don't want to fiddle with the fortifier in that way. But it does seem like for many babies, actually, they're peeing out all the calcium that we're giving them in the fortifier. What do you think about that?
So these are in children that have had suppressed PTH.
Yeah.
So I think, first thing to mention is that the normative data for calcium to creatinine ratio in infants, not just preterm infants, but in infants up to a year of age, are very poorly established. And the feeling is that normally there is more urinary calcium excretion than the kind of reference ranges that are given for children, and even more so than those that are given for adults. So I think it's important to look at that. It's a surprising, you've come up with a lot of surprising findings, actually. So Eliane has done most of the work that I've talked about when I said about the Oxford group. And I think in the context of a suppressed PTH, if you've got a high calcium and you're leaking calcium into the urine, I think regardless of what the ratio is and what the reference ranges are, I think that's concerning, because then it's in that biochemical situation that you are risking nephrocalcinosis. If you've got a high calcium and a normal PTH, I don't tend to worry too much. And that's borne out in other conditions that it doesn't cause nephrocalcinosis. But if you've got a suppressed PTH so that you're not sucking the calcium back up, then that's when you've got nephrocalcinosis. But it's interesting. It'd be interesting to look at what the kind of features are of that cohort, because one would have thought that you're just trying to replicate what they are missing out on. But it seems like that's too much for some babies.
Yeah, it just seems that the kind of one standard fortifier approach, perhaps unsurprisingly, is not fit for all babies, but I'm worried about the impact on the growth because everything is in the fortifier, so reducing the fortifier is an issue.
And are they kind of, presumably calcium and phosphorus content is roughly the same in all fortifiers, isn't it?
Yep, dietitians say yes.
Do you want to pass it backwards actually to Steph? She had her hand up.
I've actually got 3 questions. I'll ask one and see how many other questions there are. It's for Dr. Chinoy. Thank you for your talk. My first question is about, in the calcipenic state, what about if the baby is not on fortifier? So we have a number of severely IUGR babies with reverse Dopplers. Consultants haven't been happy adding fortifier. So what we're doing is we're supplementing with calcium and phosphate to meet minimum requirements in the correct ratio. So we're doing this just because we can't add fortifier. We don't want them to become deficient. But if we then get a raised PTH, in theory, we're supposed to stop the phosphate. But if we stop the phosphate, we're not even meeting minimum needs. If they're on fortifier, we don't stop the fortifier, but they're getting phosphate from the fortifier. So what we've tended to do is leave calcium and phosphate, but add extra calcium. Is this what you would recommend? So we're not stopping phosphate because they don't have any other supply.
Yeah, I agree. I mean, I'm happy to kind of throw another question that's come up to me based on that. We're presumably not giving fortifier because of the worry about osmotic load. But then surely the supplementation carries an osmotic load as well, which is always something I haven't been able to understand in my head.
It's all to do with the reverse Dopplers and the blood flow, and worry about adding fortifier in and consequence of neck, which I would be adding fortifier, but it's just some babies, severely IUGR in this case, the consultants made the decision not to add fortifier.
And then they go kind of...
Yeah, and from what I understand, it's the osmotic load, isn't it? But then you're also giving the osmotic load by giving supplements, which I always struggle to understand. But someone please explain it.
But in theory, if that was the consultant decision and PTH is raised, we should leave the phosphate just to meet the minimum basic requirement
and increase the calcium.
Okay, thank you. I won't ask my others.
I've got another question in the chat that I'm quite interested in the answer, so I'm going to jump that one in, which is from Merrin Thompson. He says, does the BAPM document address the role of protein status and preterm bone health?
Extremely briefly, yeah. It does. It basically says to optimize it rather than talking anything more. Yeah, like I said, over time, I've come to realize that it's actually much more important than I had previously considered, particularly in the really preterm ones that have just issues with developing a good scaffold in which to mineralize. And we have talked about it, but really in the terms of optimize as per other guidance. So yeah, not extensively, just recognizing its importance rather than kind of giving specific guidance about protein, because that can be found elsewhere.
Thanks. We've probably got time for another question or two. I can't see into the corner, sorry.
Sorry, I forgot to mention, because BAPM did tell me to say it and I've forgotten, that what I've said is what the working groups kind of things are. it's not been ratified because it can only be ratified once it's gone out to members. So this isn't gospel.
It's too late now.
I was told specifically by Batham to say that, and I forgot.
Hi, it's a question for Amish. My name is Michaela. I'm from Evelina. I just had a question about calcium as well. So what I have been doing in practice is recommending, because we don't routinely fortify at all, so we hardly ever use fortifier, but I've been recommending to give 2 millimoles per kilo of calcium and 1.5 millimoles per kilo of phosphate standard when we've got breast milk only, because I've calculated that that's the sort of deficit based on the mature breast milk like estimated values. Okay, but then we have had sort of concerns from our pharmacy team saying that that's quite extensive, well, quite high levels of calcium. And what we often find is that we have high PTH levels, but then a high corrected calcium level. And then they are concerned about giving high calcium supplementation in those circumstances, even though the PTH signifies that we've got a hypocalcemic state, but then we've got the high corrected calcium, that they're now worried that perhaps if we give too much calcium, we could be affecting cardiac function. So I just wanted to ask what your advice would be in that circumstance.
So I suppose there's 3 points. And yeah, this scenario comes up quite a lot. I tend to find, and this is where I started thinking more about protein, I find when I get asked about these that this tends to be in the extremely preterm group. And I often think it's an issue to do with protein, that you can't actually get the calcium in, so it then circulates in the blood. And then the second point is that the main problem with a high calcium is the impact on the kidneys. You know, the very high calcium levels above 3 or above 3.5, when they actually cause symptoms or other kind of cardiac issues, you don't tend to see. And so in terms of the outcome on the kidneys, if you've got PTH there, you're not going to see nephrocalcinosis unless you've got really high calcium levels that overcomes that PTH reabsorption. And so given that you've got high PTH, I think it is important to kind of give more calcium, unless you get, I've never heard of, in the context of preterm infants in metabolic bone disease of prematurity, have people that have calciums above 3.5. People can tell me if I'm wrong. So in the kind of 2.8 to 3, 3.1, I think it's all right to give more calcium, and that's what I tend to advise. I suppose the third thing is, wouldn't fortification just make things easy?
Just a quick one. I'm Juliet from the Whittington. What is a low PTH? We've had a lot of emphasis on what's too high a PTH, but I'm very interested with the PTH suppression.
So again, for me, it was, I typically tended, it's a good question actually, and I haven't addressed it in the framework. It used to be 0.6. I think the cutoff from that paper is 1 point something. I can't remember, but it is higher. And it's probably something we need to put into the framework.
And wouldn't it be lovely? I think it would be quite simple to get age, gestation, birth weight, normal range is much better established in our preterm population. I'd love to do it. We don't have enough.
Yeah, so it's even the one that's been done this year is 90 something infants. And I think the challenge, part of the challenge is that you need to have those that are vitamin D sufficient, because that can affect PTH normative data. So I think, and we've seen how common vitamin D deficiency is. So you need an even bigger cohort and then exclude the ones that are vitamin D deficient.
Yeah, but we do take a lot of blood from these babies routinely.
One more question from the chat, and I think I may know what you're going to say, but they would like Lorna McKerricker would like to know, what volume of enteral feeds do you recommend starting fortifier in the Batham Metabolic Bone Disease Framework, if you specify it at all?
We do, Mo. Did you remember? No, we did. I'm sure we did. I thought it was 40. Yeah, we used it at the Espegan.
Yeah, so Espegan recommend 40 to 100.
I'm sure we followed whatever the existing guidance was. Yeah.
And there's a question for the sort of whole audience from Zoe Price, which is, how does everyone separate doses of calcium phosphate and feeds practically in terms of too early fed? Well, I don't know if you want to comment on that first.
Yeah, no. Well, I get that it's difficult, especially when you're on 2 hourly feeds. I think it's nigh on impossible. But I'll see what people do, because that's advice, but you have to be pragmatic and just accept that it is difficult. I don't know how people on the shop floor as it were manage it.
So we just hands up for alternating. Hands up for don't know, leave it to the nurses to sort that problem out. Those, you can't see the audience online, but there's like 4 hands going up each time. Anyone got any other tips? Okay, well, that's fine. We'll have one more question and then we'll finish that. I don't think anybody.
Thank you. Just a very quick question for Dr. Chinoy. The difference between phosphorus and phosphate, because I think sometimes I personally get confused because the milligram to milligram ratio is of phosphorus, if I understand it, but the lab measures phosphate.
Yeah.
We give babies phosphate as a salt, isn't it? But we're expecting them to absorb phosphorus. Or is it the other way around? So how does one work this?
It causes big confusion, and I must admit our original paper can probably add it to that confusion as well by not clarifying. And so we've got a bit in the framework that clarifies that essentially if you're working on a millimole basis, I have to go back to like my GCSE chemistry for this, but if you're we actually spent a day trying to figure this out. If you're looking at the molar ratios, it doesn't matter whether you're looking at phosphorus or phosphate. It only matters when you're talking about milligrams, which is why we've kind of just got rid of the milligram to milligram ratio, because you're right, the milligram to milligram ratios that were done in those original studies were calcium to phosphorus, which has a different molar weight to phosphate. So to kind of avoid all of that, we've just stuck to molar ratios rather than talking about milligrams. Yeah.
So the question there was, is it the same for enteral and parenteral? And the answer is yes. Okay, well, we've caught up a bit of time thanks to our very efficient speakers. So we're going to end the session there. I'd like to thank both our speakers and our audience for questions. Before you all go for lunch, Christine is going to tell you about the complicated workshop system.
No, I think it's quite simple. The team has made it very simple.
Yeah.
Hear me? So for the people that are here face to face, after lunch we have the workshops. There are 5 workshops. You should have on your ID badges 2 dots. Oh, can we have the slide up, please? 2 colorful dots. The workshops are coded. So the first dot is close to your first name, is your first workshop. The second dot is your second workshop. And if you don't know what the workshops are, if you look at your program, they are color coded so you can understand which workshop is which. For the faculty members, if you have any questions about the workshops, please come and find me or Serene or Paran during the break and we can discuss it and organize it. Thank you. Make sense?
We will.
Yeah? Have you all got your ID badges?
And in the interest of people catching trains and stuff, we'll resume as planned at 1:30 with the workshops. Thanks.
Yes. Thank you.